All right, so it is now officially 10 a.m. So I am excited to say that we can start the DIPG workshop. Thanks, Paige, for getting rid of that slide. And I, again, just want to say thank you all for being here. Your Zoom etiquette is essentially perfect. And I'm going to welcome Javad Nazarian, who was instrumental in planning this workshop and is very involved in the field of focused ultrasound for DIPG. So thank you for being here, Javad. If you just want to say a couple of opening comments, and then I'll take the mic back really quickly for a quick overview of just some Zoom etiquette and a couple technical details, but I think you guys are all doing a great job so far. So thanks, Javad.
Thank you, Lauren. Welcome everyone to the DIPG Focused Ultrasound Foundation workshop. We're really excited to have everyone here today and discuss the opportunities, but also the challenges in order to make the research translational, but also to look at the opportunities within the clinical space. I want to take a moment to thank Lauren and Susie for all of the hard work that they have done to put this group together and to provide this opportunity for the DIPG and the DIPG community to come together and to discuss today. I look forward to open discussions today. And again, thank you very much to the Focused Ultrasound Foundation. Lauren?
Thanks again, Javad. And I also just want to say a big thank you to the other members of our steering committee. So Kalervo Hinian, Sabine Mueller, and Sergio Zacharoulis, and Mehmet Azdas. You guys were absolutely just critical people in planning this, and we are so grateful for your time and your ability to help us plan this workshop. So just a couple of details about the workshop. So it is, as you know, running from 10 a.m. to 2 p.m. today. There are 4 sessions. There's a preclinical session, a technology or device section, and then a clinical section, which is kind of mixed in with outcome measurement. So that's sort of melded into one. So really on your agenda, you may have just seen 3 categories. So preclinical, technical, and clinical. The first session is going to be the preclinical one. And the way this is going to work is that these sessions are all going to be moderated panel discussions. Hopefully you had a chance to watch some of the pre-recorded material, which was sent to you last week. And we will sort of discuss what's relevant from that, and then also just discuss the state of the field for these different areas as it relates to DIPG. And we hope that the discussion is fruitful and that we're able to learn a lot about what's going on and what needs to be done to advance the field of focused ultrasound for DIPG safely and efficiently. So a couple of technical notes. The panel discussions will run for about 30 minutes besides that final one, which will go a little bit longer. There will be a 15-minute Q&A session at the end of each panel discussion. During the Q&A sessions, you may turn on your camera and raise your hand if you have a question or comment. I will come on in that Q&A session and sort of call on people that have their hands raised. So please be patient with me as I try to manage that. But we really, really encourage participation from everybody here. We think that you all have valuable information to share and questions to ask. So please don't be afraid to raise your hand, turn on your camera and ask a question or give a comment during the Q&A sessions after each panel discussion. So between the Q&A sessions, when the panel discussions are going on, if you would please just keep your camera off and your mic muted so as to avoid any disruptions during the panel. I would recommend that everybody put their their Zoom view in speaker mode so that you can see who is actively speaking. And that will also sort of keep you engaged and minimize distractions from the gallery view. And I believe that that's all I have to say. I am really excited to just kick things off and hear from Javad and Mehmet, who will be leading the first of the 3 panels. So Javad and Mehmet, if you want to turn your cameras on, I'd also like to have the panelists for this session turn their cameras on. So Timothy Phoenix, Cynthia Hawkins, and Fred Wu. Thanks so much. And again, thanks for being here.
Lauren, thank you very much again for the opportunity. I have put together a couple of slides just in case for those who have not done their homework and to look at the online recording that you have generated. So a quick outline of the preclinical work for the brainstem glioma specifically, but also for targeting brainstem. Most of you are familiar with the work that Saira Ali has done in 2018, showing the feasibility of opening the blood-brain barrier in the brainstem. This is the Evans blue dye, and she has shown that physiological and histologically, the mice are not affected. The tissue is healthy, meaning that the ultrasound is not damaging the tissue. She has shown also the ability of increasing the uptake of the drug within the brainstem and cerebellum with a higher amount in the brainstem when focused ultrasound was applied, which is again really good and promising as far as the DIPG and DMGs go. In 2021, Joji and Ishida, working with Dr. Radka, they have shown that the drug uptake in this case, doxorubicin in the brainstem, focused ultrasound and doxorubicin increases the drug uptake, but also they have shown that it does increase also in the tumor. However, the data indicated that they could not increase the survival of the animal that were treated, which I think would be a good topic of discussion today in the preclinical setting. Some really exciting data from our colleague Fred Wu, who will be also on the panel, has been to work with 5-ALA that converts to PPIX. He has shown that tumor, this is rats, glioma cells that they pick up 5-ALA. We have also shown that the same is true for DIPGs and DMGs, what I'm not showing here today, but Mehmet presented in his recorded setting that some of the work that he has done in his in vitro setting. He's also shown that the combination of 5-ALA plus FUS increases the survival. Again, some of this would be great if it's repeated in the context of DIPGs and DMGs. Our colleague Hong Chen has done really amazing work with showing FUS-mediated gold particle delivery within the brainstem. Her team is really specialized in imaging, but also delivery, specific delivery to the brainstem. If you have listened to her lecture, this was really a very interesting part of her study, showing that the magnetic field produced by the MR scanner affects the microbubble cavitation in a negative way, meaning that the closer the focused ultrasound system is to the MR, the worse is the cavitation of the microbubble and the efficacy of the uptake. Again, this is another topic that I would like to discuss today on the panel. I'm excited to introduce to you our panelists today. We have Dr. Cynthia Hawkins, our colleague from Europe, Dennis van Verten, Timothy Phoenix, and Dr. Fred Wu. I welcome you to the panel, and I look forward to an exciting and open discussion. With that, let me stop sharing my screen. Great.
Hi, this is Fred here from Colombia. Thank you for the introduction. I just want to mention a small correction. The 5-ALA work is not from myself. It's a different Dr. Wu, but it is very interesting and it is in the rat model. Just to give an update where we're at right now, we have been looking at a few things in terms of the preclinical setting with focused ultrasound and drug delivery, as well as radiation safety. The big thing that we're looking at right now is not published yet, but we did show at a couple meetings, is the usage of concurrent panabinostat with focused ultrasound. As many of you know, panobinostat has been one of the high hit targets as a potential drug for clinical translation due to epigenetic modification. And one of the big issues, at least from some of the non-human primate studies, is the availability of drug delivery despite having high in vitro sensitivity. So today we have tested panobinostat with focused ultrasound. We were able to replicate pretty consistently local control benefit, and it's quite dramatic, about 4 times difference in terms of tumor volume with focused ultrasound with panobinostat. The main issue right now is that panobinostat has its GI toxicities. So the survival benefit, we've really only trended for benefit. It's definitely trending there. So we're still in this process of optimizing. In our protocol thus far, we've basically only given panobinostat once a week with focused ultrasound. And what we notice is that similar to the clinical application, you may have to hit it multiple times a week because of the speed that these animal models are growing at. So I think it's really suitable to discuss because, I think like Javad said, the preclinical research for DIPG in many parts heavily depend on choosing the right preclinical model setting to do the research on.
Right, thank you very much. There are a few really good topics to discuss here. Dennis, I would also like you to introduce yourself. You have a lot of really good expertise in this field.
Yeah, so I'm Dennis van Vuurden. I'm a pediatric neuro-oncologist in the Prinses Maxima Center in Utrecht, the Netherlands. And I'm also a principal investigator, and my main emphasis of work is indeed drug delivery, so convection enhanced delivery, but also focused ultrasound, both in the lab as going to the clinic. So we have a one-stop shop preclinically where we have an ultrasound platform and a radiator and a bioluminescence imager and PET scan facilities. So we have all things combined for the mouse models, which we are currently using. We also did some doxorubicin work, which I will I'll tell a bit more about in a second. And the other part, so clinically, we are currently establishing an InsightTech system for patients built in a Philips machine. So that's not yet Philips compatible, but it will be compatible hopefully by the end of 2022. So we can and will start studies in glioma patients, adults and children, as well as Alzheimer patients. That's our aim. So as for the doxorubicin research, we also had a study running in Amsterdam when I still work there, and we are now busy publishing that. And we also had the same experience that doxorubicin actually is delivered to the brainstem, but does not result in any survival advantage. And I think the most critical problem there is the pharmacokinetics of the mouse model. So these mice stay clear of doxorubicin really quickly, which means that the AUC in the brain is very minimal. So it's only very short that doxorubicin is present. So I think we have to think about options, for example, using LZ pump systems in mice to have longer, plasma exposure times to enable drugs entering the brain much better than they do now. For small molecules, and I think the big advantage will, eventually be in larger molecules such as monoclonals, which will stick to the local microenvironment much longer. So that is, at the moment, a short introduction on my side and what we did.
Thank you, Dennis. And Cynthia, your team has published, or you've been a part of a team who's published on the piglet models with the MR-guided ultrasound, maybe, and we will be discussing different models that will be tested. If you could please introduce yourself and your expertise.
Sure. So I'm a neuropathologist here at SickKids. So my experience, I guess, is mostly with, looking at the morphology of the brain or the brainstem after the focused ultrasound has been applied. I looked at both the mouse model, so the stuff that Sarah did with Dr. Rutka, as well as the piglet model. And I mean, I wouldn't say the brains are totally the same if they've had ultrasound versus if they haven't. There are vascular changes there. And I think it is just something we need to be careful of going forward, especially in the brainstem in human trials. But you know, it's not that there's major destruction there, as long as you don't overdo it with the ultrasound. And then obviously, you know, I just in general for tumors like DIPG, or even for the supratentorial diffuse gliomas, you know, it's important to remember that, you know, this will be, I think it's a key piece to drug delivery, but, you know, these are very infiltrative tumors. And so, you know, local control is basically what we can expect if we've opened the blood-brain barrier locally, and that we probably are going to need to combine this with you know, different strategies that will target the cells that have already gone past the region that we've applied the focused ultrasound to. So those are just my preliminary comments, I guess.
Thank you, Cynthia. So blood-brain barrier is a good lever to have Tim introduce himself, please.
Yeah, so I'm Tim Phoenix. I'm in the University of Cincinnati and Cincinnati Children's Hospital. So I run a research lab here, and my lab's interests are in tumor vascular interactions, specifically blood-brain barrier function. And we've also gotten into sort of building preclinical models, things like DIPG and high-grade glioma models. So yeah, we've been sort of building these models as complements to what's out there right now, looking at blood-brain barrier function, just sort of to summarize some things. So we do see sort of maintenance of blood-brain barrier function across these different models. So things like patient-derived xenograft models, or these in utero electroporation-based models that we've been making in mice. I think one of the sort of points that Dennis raised with mouse pharmacokinetics is something that we can touch on later. Some of the utilities of different model systems. But yeah, the blood-brain barrier is definitely sort of seems to be better maintained across DIPGs compared to other types of pediatric brain tumors like cortical high-grade gliomas or some of the medullos. You know, very infiltrative and diffuse, and even in some of our models that sort of become sort of more dense, they seem to maintain it even better than what we see in the cortex. So there might be some regional differences as well. So I'll pause there and we can talk more about some of these things.
Thank you very much, Timothy. I would also like to ask my colleague Mehmet Oldes to join with his camera and to introduce himself quickly.
I think my camera is somehow not working. I guess now it's working, right?
Yes, now you're here.
Hello, so my name is Mehmet Özdas, and I've been a postdoc with Javad since now 1 year or more. And I previously developed a technology for local drug concentration in the brain for psychiatric disorders mainly. And this was a work that I have done in my PhD with Fatih Yanek in ETH. And during my time with Javad, I developed some high throughput in vitro systems to screen ultrasound sequences and drug concentrations and different drugs to basically identify drugs and ultrasound sequences that are able to synergize together. And we have tested so far 5 ALA with our system. I think you have a video, I showed a video of our system. So we put a lot of work in there to solve some of the major problems, and we are still actually working on them to advance our system to make it even more high throughput. Anything else, Jawad, should I clarify more?
I think that's fine. We'll discuss this during this discussion. This is good. It seems like, so we do have in vitro system, as Mehmet mentioned, and others have published, that we can look at sonodynamic therapy, sonosensitizers. We have in vivo models, but perhaps we can start the discussion with what are the good in vivo models that we can test, or is there a good in vivo model? Does the size matter? If you guys can discuss on your expertise, Cynthia, you have done a lot of work in comparing. Denise, go ahead.
Yeah, I think referring to what both Cynthia and Timothy have been alluding to, this is quite a diffuse disease. So I think it's really also important to, per model, acknowledge at what time point you want to start treating the mice. So looking in each model how the diffusity of the tumor cells at certain time points after injection is. So we have to define and maybe harmonize time points of starting and applying FUS. For example, in the DIPG-7 model, we have seen that by day 21 or day 28, cells are already diffusing to other parts in the brain that you cannot even reach with ultrasound anymore. So I think standardizing per model at what time point you want to treat, I think is an important aspect.
Yeah, I mean, I would agree with that. The model choice is critical. I mean, that's true for any type of in vivo study that you're doing for DIPG. I mean, for other models too, but you know, we struggle a little bit with this in terms of, you know, the same thing. If you're going to start a chemotherapeutic agent or a targeted agent, you want to pick a model that isn't so aggressive that the mice are going to die in like 2 weeks or 3 weeks, because the chances of you getting a drug to work in that circumstance is really small, and you could miss things that may be potentially useful. You know, on the other hand, there's practical issues, right? You don't want to choose a model that it takes a year for the mice to die. So, because it's kind of long to do those types of experiments. So, you know, we've tried to settle on, you know, models where the mice come down somewhere, you know, 2 to 3 months. And we try to pick ones where morphologically, you know, when we look at the histology of those brains, that the tumor cells really have diffusely infiltrated, as opposed to forming a big lump in the middle of the site of injection, which is what some of them do. But certainly there are a number of DIPG models that are quite diffusely infiltrative and do not just form a ball. So to me, those are the best types of models to use. And I completely agree with Dennis, having properly characterized it and knowing what happens in the context of no treatment and at what point is it infiltrating beyond, say, the area that you're going to be applying the focused ultrasound. Certainly, if you're doing that, your chances of seeing a difference are going to be small.
Yeah, and also maybe with regard to what Timothy has investigated, the number of vessels that needs to remain intact, of course. So if you get a destruction over the disease course of the intratumoral vessels, then it's no use of applying microbubbles and ultrasound as well. So that might also differ in between models. Right, Timothy? Or
yeah, so you definitely see like these differences across the models, and you know, whether you're choosing a patient-derived model or a mouse model, I think, you know, depending on which one you choose, you know, there's different levels of aggressiveness. And some of these disruptions might be just local, and, you know, you might have one little disruption while the rest is intact and diffuse. And, you know, I think this also contributes to sort of mortality within the study. So we've seen some in our models where they'll develop symptoms and they can last with those symptoms for weeks because they're not sort of forming these hemorrhages and actually dying, which might be useful in terms of treatment courses. But yeah, it's, you know, you have to think about all of these things that both of you've mentioned in terms of all these different models and the utility of each one.
Yeah, I mean, I do think it's also important. So if we think about what do the patient tumors really look like, they also are sort of variable in terms of the type of vascularity you get. And so, you know, probably 3/4 of patients will at least have that vascular proliferation, you know, not properly formed blood-brain barrier areas, but they will all have areas where the vasculature looks relatively normal. And so to me, there's two things to consider there. One is, okay, so then you probably do need something to open the blood-brain barrier if you want to get a drug in there that wouldn't otherwise cross. But, you know, we maybe also need to think about what's focused ultrasound going to do to a whole bunch of abnormal vessels. And in some patients, they can have quite a lot of vasculature there with very kind of thin, you know, not properly formed walls. And are we going to cause a hemorrhage in that type of a vessel? versus, a patient where they don't yet have that vascularity. And so it's, and I don't think the animal models are maybe fully capturing that. And certainly, some of the at least the initial studies have largely been done in the context of either a normal brain and what happens, or a bit of an infiltrative tumor maybe, but the vessels are not as abnormal as what you would see in some patients. So I think it's important to think about those things too, and we try to move it into the clinic.
Hey, Fred here. Sorry, just to add, I think I fully agree with everyone's comments about having a model that's diffuse. Clearly, a ball tumor is not representative of what we're dealing with, and the barrier is probably already disrupted anyways. That being said, I think there's of large value to also have a syngeneic model of some type, mouse model that has an intact immune system, mainly because as important it is to find efficacy, it's just as important to know what toxicities to expect before translation. You are opening the blood-brain barrier, and there's ample data in normal brain, Alzheimer's brain, and whatnot for local inflammation from that therapy. If you add in factor of death from tumor cells and whatnot, using just human models and immune void animals, you're missing a lot in terms of that aspect. Also, clearly opportunities for immunotherapy and whatnot. So, I think that's another important factor to consider, that, just using human model, you may miss out on a lot of opportunities for research. The other thing I think is also important is, I'm sure here everyone does DIPG, but some of the participant may be ultrasound specific. With the biopsy data, H3K27 mutation is important to have. So whatever model you're using, it's important to make sure that that's representative of the histology and the markers.
Right, thank you so much. You actually started a new dimension to this discussion. Before we move into the immune competent models, one of the ideas of this focused ultrasound meeting was to develop a way of us to sharing the data and specimens that we have. And as Cynthia mentioned, the blood vessel, the number of the vessel, the thickness, or the characteristics of the tumor spread is really important. Perhaps that's something that we can discuss through the Focused Ultrasound Foundation, that we could share this data and have them centrally reviewed by pathologists, that we know when we talk about an uptake, are we talking about in which context? Did you have more vascularization in a tumor that had more uptake or not? So then immune competent, that's a very good subject that you started. Is that even feasible for us to do? Has anyone tested FUS in immunocompetent?
Yeah, we have.
Animals?
So we're using so it's a gem model that the Oren Becker had isolated cells in vitro for mouse syngeneic model. It's really interesting model for a few reasons. One, we've done characterization studies using MRI, and what you find in these models is that they actually first develop T2 hyperintensity, T1 contrast negative tumors first, and it takes about a week and a half after that before the contrast enhancement shows up. So you do have a diffuse component before contrast enhancement, which is really interesting to us. The second thing that's interesting to us is that here at Columbia, we have a huge computational biology group, and they've been doing sequencing of large human data sets, including the Pacific Pediatric Neuro-Oncology Consortium and also the Brain Tumor Consortium patients. All in all, what we found is when we sequence this mouse line, it basically shows protein interaction very similar to the human data set for both independent human groups. So I think from a molecular standpoint, a radiographic standpoint, it's an optimal model for us. So we have been using that model for our panabinostat studies. And just to add on our clinical trial that we've been doing, we've been opening blood-brain barrier in kids with DIPG relapse. We've delivered over 20 treatments thus far and have had 0 grade 3 toxicities. So generally speaking, it's been pretty well tolerated.
Can I ask a question about that mouse models? Does it also mimic the human situation with regards to the microglia and macrophage activation or non-activational state?
I haven't looked into that. That's on top of the list of things we want to do. We were hoping to actually, let me take it back. So one of my collaborators is looking at that specific model with radiation. And there's a new form of radiation called flash. So they've been radiating this model specifically, and they did see radiation-induced microglia infiltration after radiotherapy. So there is a subpopulation that's characterizable.
Yeah, I think like with the sort of immune competent models, there's a few out there. So you have some of the traditional genetic mouse models that have been made by Cynthia's group and a few others. You have the RCAS-based models that Oren's group's been using for the past decade. You have electroporation-based models that we've been using and other groups have been using. I think there's benefits to each of them. Obviously there's limitations in terms of their use across the world, and just the ability to set some of these things up or do them. So, making sort of syngeneic models from some of these, we've been doing that now with Esther Huleman's group out where Dennis is. So, I think making these and sort of distributing them, sort of the way that the patient-derived lines have been done over the past decade, will be definitely useful to the community.
I think that would be really great as well.
Yeah.
If after today's meeting, a lot of us, we can find one person who's like the central collector of all the lines and make it available for the community. That would be like a game changer.
Great. So I think another topic that we should also discuss is that we should also consider preclinically testing drugs or sonodynamic therapies that don't even that would not require opening the blood-brain barrier. Right? Drugs that would essentially get into the tumor, including 5-ALA, and test those in a preclinical model. Because as we just discussed, it may vary the opening of the blood-brain barrier, or it may not be clinically feasible. Dennis, have your group had any expertise in testing the drugs that do cross, but are also sonosensitizers?
Yeah, so we perform a lot of drug screening on all our patient cells. So, we have a drug library of drugs that actually are predicted to cross, and a drug library that are predicted definitely not to cross. And there we indeed find candidates, but we always try to see whether it can be further enhanced with FUS, even if it does cross. I mean, it can be maybe further enhanced, but we, again, as I started off with, we do see problems pharmacokinetically that we need to find new solutions in how to, for longer time periods, give these drugs to these mice. And also look not only at Lipinski rule of 5, but also, of course, whether these drugs are substrate for ABC transporters, because that is also, of course, influencing it to a large extent. And there are some, I think, interesting ideas there that if you might inhibit ABC transport from the abluminal side, maybe using focused ultrasound, that you might thereby enhance other drugs that they stick longer into the tissue microenvironment. So we are actually trying to find combinations of those concepts.
Thank you, Dennis. And the platform that Mehmet described that we have in Zurich is also in vitro. We'll be happy to work with you to look at some of the drugs that we could potentially test. But again, what I really hope to happen within this Focused Ultrasound working group, that we would have working groups that we will be discussing this more often, maybe on every other month basis, that we would just share data and see where the gaps are.
Yeah, I think what Dennis was saying with the sort of mouse pharmacokinetics. So, you can see this with different drugs. And one of my office neighbors who works on adult GBM sees this with one of their drugs of interests, where it's, metabolized in the mouse super quick. And I guess, depending on what models are available. So for their drug, it's not metabolized as quickly in rats. So whether different rodent models would be better for some of this is something else I think should be considered.
Yeah, or use liposomal formulations that, but that's of course different. So that gives a very slow leakage of a low concentration of drug, and the question then is whether you, with that method, will achieve high enough concentrations in the brain.
Yeah, and then just things like patient-derived versus mouse models and genetics of targeting mouse proteins versus human proteins. So something we've seen with MDM2 inhibitors. So they work really well in human cells. They do work well in mouse, but not as potent. So some of the binding of these drugs might be a little different. So all of these things that come up as you start to do this.
Yeah, what we tend to inject. Oh, sorry. So go ahead, Cynthia.
I was just going to say, I think that's why, Javad's idea of having kind of a working group that everyone shares some of their experience, because I think, there are a lot of nuances and a lot of tricky things, and it takes you decades to acquire all the experience in all of this. So for sure, if you have a group that can say, well, no, I tried that and this doesn't work because of this, it might be some things that you didn't think about it because you haven't done that model before or whatever. So I would just definitely support the idea of sharing the experience with other people. And also there's certain people that do things better, like, our lab, like pharmacokinetics, no, that's not our expertise at all. So if there's, if we got something to a point where we think it's an interesting potential drug, there's another lab that maybe wants to take it from there and do that part of it, for example.
Yeah, absolutely. Cynthia, I will work with Lauren and Suzy at Focused Ultrasound Foundation to set up these. And we are also working with Virginia Tech to develop larger models for focused ultrasound. And I totally agree that we don't have to relearn everything. We could just work with the team and learn from their expertise. Dennis?
Yeah, and I think it's also what I try to learn my PhD students is always go back to the what is known about these drugs. So look at the MTDs in phase 1 studies in adults and see what actually drug levels you can achieve, because you can always achieve maybe super physiological drug concentrations for small amounts of time in mouse models, but those are completely irrelevant then ultimately for the human situation. So try as much as possible to mimic what is known from levels in drug levels in humans and go from there. And we have a system now in place in our lab that is able to mimic with microfluidic system actually what the AUC is going to be. So you can actually mimic the plasma levels, how they rise and how they drop in vitro, and that you can sort of mimic with as if it would be the local tissue AUC as well, and see whether then on neurospheres and on mini brains, there is an efficacy on these tumor cells and on the normal counterpart. So that could also provide you some kind of algorithm by which you choose potentially effective drugs and drop those that are not achievable in the clinic.
Can I say something, Janet?
Sure.
So there is for me at least, there's one thing that unknown, the tumor microenvironment in the DIPGs, the biomechanics of the DIPGs. They are not. I haven't seen studies that could also, of course, affect the drug diffusion to the tumor, the tumor cells. And I was wondering if this would be possible, when the patients go to biopsy. And would that be possible to just give them a potentially a drug that's close to the trials, and to see what kind of concentration can be achieved actually in the patient brain directly? Probably this could also give an idea how much can be achieved in the patients even before the this kind of trial has started.
Yeah, I think, Dennis probably knows more, but those type of phase 0 trials have been proposed, and I think it's doable in some patients, but it you know, a lot of the times the clinical context for DIPG patients is, you know, they're often quite unwell, and you usually try to get to radiation as quickly as possible. And so adding the extra time that it takes to give somebody a drug and then wait and do their biopsy and then to get them to radiation, there's many patients that you wouldn't be able to do that. So it's a great idea. It's just practically not easy.
The other limitation is really, you know, when you're talking about biopsies of the brainstem, you know, the sample you get is probably just like a small piece of a lead for a lead pencil, a mechanical pencil. You know, that's all you get. And once you get that, you have to make a diagnosis first. So, you know, even if you took all of the tissue that you got and send it for, you know, LCMS or whatever for testing drug concentrations, you clearly won't have any sort of meaningful tissue to do that. The only window of opportunity for this to possibly happen is in patients with diffuse midline gliomas in the thalamus, because some of those you may be able to resect and get ample tissue for. But again, I think it will be a very hard sell to get that in the upfront setting, in the relapse setting, where there's a symptomatic mass that's amenable to surgery. You may have an opportunity to do that. But again, the big issue is that you're answering drug delivery in the thalamus as opposed to drug delivery in the brainstem, which clearly the blood-brain barrier is very different.
Great. So a lot of good stuff to discuss. One last thing I wanted to bring up is so if collectively we do all of our in vitro study to find sonosensitizers, move those to mice, and then at some point it seems like we do have to invest into larger animals. And the only reason that I have in mind is really the size and the depth of the ultrasound that has to travel. Is that something that we could discuss for the next few minutes? Do we think that mice or rats are enough clinically relevant, or do we really need to start looking into larger animals? Cynthia, you've done some of the work, maybe you can.
You mean like the pig model?
Pig models, right?
I mean, the pig model, of course, works well if you're trying to look at effects of the focused ultrasound on normal or relatively normal brain. Pig brain is obviously a lot bigger, but you know, still very doable in terms of checking the morphology. The morphology is different than a mouse, but different than a human. I would say that the limitation is the number of, you know, like we don't have tumor models in pig. So I've used that model, but, you know, I've seen the focused ultrasound. It's used actually also as a model for cardiac arrest and looking at ischemia, but we don't have a tumor model. And then, you know, I suppose there would be something like a dog where you would have actual glioma models. Maybe, but the number of people that can do dog models is small, right?
Right, but there are dogs that develop glioma spontaneously. And again, that's something that we want to work with Vigiantech. Our colleague Eli is on the call as well today. There are immunodeficient pigs that could potentially be built too. I guess, and all of this is really expensive. And as you said, Cynthia, it's hard to come by this spontaneously developing dog models. But if the size is really an issue here, maybe we can have a workup where some labs will do the in vivo, in vitro work, some labs would do in mice or rats, and then the top drugs that would work well would go to a smaller lab who would only focus on the larger animals.
Yeah,
Dennis,
I think.
do you have any comments? Go ahead, sorry.
Sorry, there's huge value for large animals, and really it's less so about the mechanisms and whatnot, preclinical stuff, but more about the practical clinical delivery. You know, the clinical devices nowadays, aside from SonoCloud, the implantable device, which is non-specific large volumes, you know, everything else opens a small focus. So clearly to date, no one has been able to show if you can open the entirety of the brainstem tumor safely, except for mice models, right? Like we just don't know. Now, everyone and every device has an approach that they're trying to do to open a bigger volume, but unless you have a big animal model, it's going to be very hard to find that answer. So our strategy so far within our clinical trial sense is that we've been working on a dose escalation phase 1 feasibility study for DIPG. Essentially, we open one extra focus every 2 cycles to try to get to a volumetric understanding of how much you can actually open. But even then, our maximum is 3 foci. Even then, that's just a small part of the DIPG. So without a large animal model, you clearly will not be able to know if we can even open the entirety to cover the brainstem tumor safely.
Right, thank you very much. I think at this point we will open the open Q&A session. Lauren, and if there are any questions that have come through the chat, please.
Yeah, so I haven't seen anything come through the chat, but I think we're going to try to unpin you guys so that we can see everybody. And please, if you have any questions or comments, just raise your hand and turn on your camera so that we can interact with you. And I will call on you. For right now, I do have actually a couple of questions myself. So since I don't see any hands yet, I will go ahead with my
I'm
questions.
sorry to interrupt. Can we ask Sabine Mueller to maybe talk about the phase 0 design for DIPG they've successfully completed? It was in the text.
Yeah.
And I wanted to comment on that. So first of all, good morning and thank you for a great discussion. So I totally agree what Cynthia has said, right? I mean, it's not for every patient, but there's definitely a subset of patients we see where their neurological symptoms are not in a way that you immediately urgently need to start radiation therapy. And I mean, these are the patients who can have a biopsy, prior to radiation therapy, but also to point out the patients who need to be urgently, started on radiation therapy, they can also basically have a biopsy after radiation therapy, and we've done this successfully. And in our latest trial, we will offer target validation phase also for patients who didn't have an upfront biopsy after radiation therapy. So I think there are many options. And then PNOC 16 completed right now, at least for high-grade gliomas, and for DIPG, a target validation study for fimopinostat, which was led by Cassie Klein and John Crawford. And so far, we have been successfully able to detect the metabolites of fimopinostat in all the samples that were collected. And we are now currently looking into sort of downstream target validation as well, because it's one point, right, to measure the concentration of the agent, but the other one is obviously trying to look at the mechanism of action. So I do think it's feasible, and I think technology is improving. And there's also, I think we learned a lot about how many cores can be taken safely. And, this has been increased in recent larger multi-site studies from maybe initially 3 to 4 cores to 4 to 6 cores. So it all depends. I mean, I would agree that obviously in the DMGs located in the thalamus, where you can more safely potentially even do a partial resection, you have more tissue available, but it is feasible, I think, in DIPG in obviously a selected group of patients.
Yeah, and I would also advocate trying to look at other means of assessing extra drug delivery, for example, by PET imaging. So 11 carbon or 18 fluoride labeled drugs, or for bigger molecules, zirconium, for example, to see whether there's enhanced uptake with ultrasound, so non-invasively.
Yeah, I think that is ideal, right? I mean, because that you can also follow it repeatedly. Obviously, a biopsy, normally you do this once, maybe twice in patients, so that you don't understand. But we're still trying to understand how then the therapy affects and changes over time the effects, right? And that has been challenging in DMGs, right, to get on treatment biopsies. I think the target validation design is the closest to it at this point, but I would fully agree that other markers, I mean, we are looking at CSF as well, which I think can maybe serve as a surrogate for some measures, but it's obviously very different, right? So I think to look at really the penetration within the brain tumor tissue, I agree. Anything in terms of imaging, labeling the compounds, etc., would be ideal. But it's obviously a longer process to develop these things, and it comes with additional complexity.
Thank you. Yeah, that's very interesting discussion, and I'm just so grateful for all of you. Like, we are very happy to work with you to create a working group where you guys can have these sort of discussions with each other on a scheduled basis. That is a huge mission of ours, is to just enhance collaboration. So I would be happy to, to set that up, and I will absolutely follow up with you after the meeting. So be on the lookout for emails from me regarding that working group. I do have a comment, first of all, to the point that was just brought up. We have been obviously thinking about how we can better confirm that drugs have been delivered at an increased concentration, or whether or not that they have in other brain tumor models. So we recently had a GBM workshop, and one of the main discussion points at that meeting was that we needed to have better methods to confirm delivery of drugs. So we talked about radio labeling, we talked about mass spec, we talked about a couple of other things, and there are projects underway in glioblastoma models to address this question. And I believe that those will be translatable to the DIPG population as well. So just a comment on that. I have one question, and then I do see that Susie also has her hand raised, so I will get to you, Susie. But I actually have a question for Cynthia. Thank you for being here. And I was wondering if you could speak a little bit more to the vascular changes that you mentioned that you see with the focused ultrasound treated specimens. And I was also wondering if you, or whoever the viewer is, the reader of the slides, is blinded to whether or not the mice or other animals or humans have had focused ultrasound or not.
So yes, I was blinded when I looked at it. So you can, the vessels are a little bit more distended. And in some cases you do see little hemorrhages around the vessels. Those would be the main changes. You could, once you start looking at a bunch, you sort of start to guess, oh, this is probably the one that got focused ultrasound. But yeah, blinded, we were blinded, or I was blinded at the beginning.
Thank you. All right, I think that was the only question. I think all my other ones pretty much got, oh, I did have one other thing actually. So you guys kept speaking to the models there, how there were some models that were more ideal in terms of their, being diffuse and more like the human DIPG that we see. Can you speak to like specific models, like give me the details on what those are called, or is it, that's pretty well known in the DIPG community, I imagine, but are there a couple of models that are being used by all of you guys, or are you guys, sorry, I know that, I don't know if that came across right, but.
Lauren, I think one of the goals of having the working group, it would be to really share the models, but yes, typically we have xenograft models that we generate by injecting the tumor cell, the patient cells. There are very few gem models that we use as well. But again, I think working through a collaborative team where we could have centrally reviewed the stains and models would be very informative. One more comment about what you mentioned for the drug penetration. We had developed a model in both labs in Washington, DC, and also in Zurich, where we had a microcatheter implanted into the mouse brain. And in Zurich, Mehmet actually did this by implanting the microcatheter into the rat brain. And the idea was that then you would do FUS and lifetime collect the artificial CSF that you inject into the catheter within the brain parenchyma and collect the drugs that are getting in. There are, of course, difficulties associated with this, but this is something that we could discuss within the preclinical working group and develop. It seems to be an important platform to have.
Thank you, Javad. Susie, I did see that you asked some questions in the chat. Would you like to comment or have further questions?
Yeah, no, thanks everyone. Really fascinating conversations and points for future work. My question to the group was, I think Cynthia brought up the fact that we need these preclinical models to have an infiltrative component. right? But when we're doing the preclinical focused ultrasound targeting, we're targeting the tumor itself, but I'd like everyone to comment on how much of the peritumoral tissues they're also targeting to get this infiltrative component. And if people have found a difference in the ability to get the drug into that infiltrative component and what the response is in those areas of infiltration versus the main tumor. I think, Javad, your comment about using microcatheters to monitor this could also help that question about looking at the tumor itself versus the infiltrative component. So if we could just have a short discussion about that and maybe standardize some of this preclinical work to make sure we do address both components. I'd love to hear your thoughts.
Sure, I think it would be important to look at the non-tumor cells, healthy cells, and see if there's any damage that has been done as a result of drug uptake, right? And that's the work that we could do with Cynthia and bringing her expertise. DIPGs are infiltrative, so they are sitting in the presence of a host of healthy cells. We do need to address what you mentioned, Susie, to look at the uptake within the areas that have fewer DMG or DIPG cells infiltrated, but also at the toxicity that may have to the healthy environment of the cells. And again, I think its working environment would be ideal to address this question, or the microcatheter that we mentioned. Sabina, you also have your raised hand.
Yeah, I think it's mainly a question really for Cynthia. I mean, I know we discussed this a little bit, but I think that there's obviously a lot of focus on sort of the blood vessel integrity and density within these brainstem tumors, and how maybe a diminished density could impact sort of, you know, this whole approach. And I know this is sort of early studies, and you know, there's a lot of, I think, papers coming out, but I wanted to get your thoughts on what you think. Really, do you foresee this as an issue in applying this technology, or what is your sense from the vasculature in these DIPG, and does it differ between DIPGs in the pons versus thalamic tumors? Yeah, just anything.
So I think
you have 2 minutes before you have to run to your teaching.
I know. Okay, 2 minutes. So, and I can talk later more, you know, but so there's quite a bit of variability from patient to patient, and I think probably in disease stage as well. Obviously, we know that at least surrogate wise, based on imaging, and that, you know, our classic patient at presentation has a diffuse T2 bright pons, but we don't actually see a lot of contrast enhancement, at least, you know, in many patients. And we sort of assume that contrast enhancement means leaky blood-brain barrier, and that probably there's some vascular proliferation there. You know, certainly at the time of autopsy, you will see areas of the tumor where there's quite a lot of vasculature in many patients, including very proliferative vessels like you would normally think of as in a GBM, for example. There's also a lot of vascular changes from radiation itself. And then, you know, you will also see other areas of the tumor where you're looking in more like a diffuse astrocytoma, where the vasculature is pretty normal and you're just seeing infiltrated tumor cells. And I think most patients have all of those components, and some have basically a totally normal vasculature everywhere. So it is variable, unfortunately. Yeah.
And I wonder how then, you know, if we're starting this bringing into the clinic, how we could assess for this and bring it into the assessment of responses, right? Because I do think that might be a critical component that I don't exactly know. I mean, we can obviously look at, you know, like you were saying, contrast enhancement, you know, and can think about correlating that, but I think that will be tricky, right, to fully get at this. But I think it might be a factor that will influence, you know, response to such a therapy.
Yeah, agree.
Yeah, we in the Netherlands, our upcoming DIPG trial will also investigate the role of 7 Tesla in that respect to maybe see whether there will be interpatient differences in vascular density.
I think that's a great thought, Dennis, to really do this more high resolution imaging. And that's something we should really think about including in the trials. Yeah. Mm-hmm.
More to come on the clinical trials aspect of things here after the next panel. So I'm actually, unfortunately, going to have to cut us off here. I really appreciate everybody that was on that panel. Thank you all so much. Javad, thank you so much for moderating that session. So at this time, we are going to transition to the device technological panel. So Kalervo will be moderating that session. If you could please turn your camera on and unmute. And then also Hong Chen, Gregory Charnada, and Elisa Konafagu, can you please turn your cameras on and your mics on, and we will get this kicked off. Kalervo, I'm going to hand things over to you.
Well, thank you so much for everybody coming and listening. I make a little summary of our talks that we gave. Unfortunately, there were several talks that we planned and we were not able to get speakers for various reasons. So I need to summarize even more than was talked on those talks. So number one, looks like I'm missing one slide, but so this disease is quite difficult because it's localized in the center of the brain and very close to bones. So that creates several issues. Number one is that there could be standing waves related to the bones that are close by. And so we'll discuss a little bit about that. The second issue is, of course, that the patients are young, so the skull bone might be different than in adults. And that's another issue. The good thing, of course, is that the tumors are central, so it's easy to focus through the skull because of the angles are pretty much normal, and you can get a good penetration. So this is a study that was done a few years ago where the InsightTech system was used and fields were mapped inside a skull, human skull with a hydrophone, looking at how much the aperture has an impact on generating standing waves next to the skull bone. And here are examples of the results. So this is the actual measured curve, and the red one is the simulated curve. They are more or less overlapping, and you can see that here is a standing wave pattern that is formed. So our simulations and experiments seem to work pretty well predicting those patterns. So how do they look? So here is now a small aperture where we're activating only this section of the hemispherical array. And you can see we have a long beam coming here, and it's bouncing and generating standing wave pattern right next to the bone. Whereas when you use the whole aperture, you have very sharp focus, and here you can see that the standing waves are eliminated. When we look at different apertures, here you can see those patterns, how the focus changes depending on the F number. And this graph now gives you the relative fraction of standing waves related to the F number. And you can see that when you have a hemispherical array, it gives you the best result with only 10% of the standing waves are contributing to the amplitude. So this is something that needs to be taken into account when we are treating patients to be sure that either there are no standing waves or we know what the standing waves are, so which generates demands for the treatment planning. The second thing is the young skull. So here you can see the only paper that I was able to find. This is from the sick kids here in Toronto. They did a study where they took a neonatal skull post-mortem and then had a hydrophone in, and then used a phased array to map the signal propagation. They used 1.1 megahertz and 1.2 megahertz, which are higher than we usually use in treatments. The insertion loss was quite a bit smaller than we have with the regular human adult skulls, and the same way the time of flight effects were small. And so the conclusion is that we don't have much data, but skull might have a much less impact than adult skull, and so the focus, it might be easier to focus, might not need to correct as much as with other adult skulls. So now, what are the current systems? Elisa presented a nice talk about her system, which is now in clinical testing. This system has a single focus transducer, 250 kilohertz, has passive acoustic mapping and assume a linear array. It's a single element transducer, so there is no skull correction, and the focal zone is relatively long. And here you can see an example of the focal zone, how long it is. It has been used in patients, so a nice blood-brain barrier opening in this case. The other system that was not discussed in this session, but Hong gave a talk, and so the InsightTech system, which has been used extensively with other tumors. So this is a hemispherical system, is MRI guided, uses skull corrections and monitors acoustic emissions. It doesn't map the emissions, it listens them and then uses the location of the focus to determine where those emissions are. And this is the very first patient treatment that was done with this device, showing how precise the focusing is with this device. And here are some of the recent results showing how the blood-brain barrier can be modified to increase antibody uptake inside the tumor in fairly central location in this case. So this device can modulate the blood-brain barrier anywhere inside the skull cavity. So what are the potential therapies? Blood-brain barrier modulation for drug delivery has been now used by several people, and it seemed to be feasible and controllable. And the two devices have been clinically tested. You can get more drug in the brain, but does the drug work? That was presented in the animal study group. So that's a question. We need to have drug that actually works in this case. The other possibility that Zhengkai Wu talked about from my lab is a work where we have published a previous paper. This is new work continuing, where we looked at different sonication parameters, the influence on them on the tumor volume with the sonodynamic therapy. And here we use the frequency that can penetrate to the skull of 580 kilohertz. And in this case, you can see a tumor volume here, and there's a days. And with optimized exposure, you can have a complete disappearance of the tumor, 100% survival in those tumors. So this looks very, very promising. This therapy is controlled by the ultrasound intensity and the energy potentially. We don't know exactly what are those parameters, and there is no bubble emission, so we don't know how to control it. Maybe we can use radiation force induced displacement to characterize the acoustic pressure amplitude, because that seemed to be the determining factor. And then, of course, we have questions. I mean, is this drug accumulating in these tumors? The final thing is radiation therapy enhancement with bubbles, which Greg Sarno has been exploring for many, many years, and he is in the committee. So he has shown some nice results, several results in animals. Again, this is feasible with current clinical devices, easy to do, but can be controlled with bubble signals potentially. Don't know exactly what the signal is, but it's controlled, but it is possible. And does it work with brain tumors is an open question. So as a summary, tumors close to the bone, focusing is important. Allocation is central, so we can have effective access. Skull properties are different than in adults, so predictions might not be so easy, but the therapy might be easier to do. There are two systems that have been proposed for treatment so far, and they seem to be working. Blood-brain permeability is potential therapy. Sonodium therapy might be even easier and better. Bubbles and radiation therapy potentially also. So thank you so much for listening. So now we move to the panel discussion. So maybe we can each of us can introduce ourselves. So maybe we start with Han.
Hello, everyone. It's such a pleasure to be the panelist along with Clairvaux and Elisa. So my name is Han. I'm currently associate professor at Washington University in St. Louis. So we have been working on drug delivery to the brainstem area for several years, and Clairvaux already gave a nice summary of all the technical challenges that we have been facing. So that was a quite nice summary. I think I'll end here and looking forward to more discussion with the panelists.
Okay, Elisa, why don't you?
Yeah, I also want to echo Tom's enthusiasm. It's really nice pivotal moments, I feel, for what we do in the clinic and what we've learned also from all these animal models. So I forgot to introduce myself. I'm Elisa Conafago. I'm at Columbia University in biomedical engineering. Oops, fuzzy audio. Okay. Hopefully you guys can hear me. Maybe Greg can start and then I can try to fix my audio. Sorry. I have a problem with audio.
Greg Tornata from Sunnybrook Health Sciences Center. I'm a radiation oncologist with an interest in focused ultrasound for enhancing radiation effects. And we've been working on that here at Sunnybrook now for probably 10 years and are in clinical trials, not in the CNS yet, but happy to discuss possibilities there today.
So maybe we start with that, Greg, if you could give your view, okay, well, how could we apply the technology of enhancing the radio sensitization with this ultrasound and micropulse for this tumor especially?
So I actually think one of the easiest or quickest roadmaps to uptake of focused ultrasound for therapy purposes is, rather than displacing an existing treatment, is to augment it. And we've actually now shown over the past decade that there are very good results in terms of augmenting effects of radiotherapy. With microbubbles and low power focused ultrasound, one ends up with a 40 to 60 fold enhancement of radiation effect in multiple tumor types. And we've now moved that to human trials in breast and head and neck tumors. But I actually think it's applicable to all tumor types. The biology is somewhat unique. It involves stimulation of the endothelial cell membranes and then a particular genetic pathway that's activated with ceramide, which is a cell membrane stress molecule being produced. And that seems to be key to the mechanism. So I actually do think it's a very good opportunity to enhance an existing therapy and to make it much more potent. And in the radiation oncology community, there's no such known radiation enhancer. In the past 40 years, all experimental work with chemical radiation enhancers has, for the most part, failed. So a biophysical mechanism like this actually is very promising and enticing.
Thank you. Elisa, is your sound working now?
Can you guys hear me okay now? All right. Okay, so I will introduce myself really quickly. So I'm Elisa Conafago at Columbia in biomedical engineering, and we've been working in the area of blood-brain barrier opening over more than 15 years now, and I look forward to sharing some of our experiences both in animal models and also in the clinic.
Thank you. So Elisa, maybe you could comment on what Greg just said, how do you see that we could use radiation enhancement with bubbles? How would you control it and how would you treat it?
So this is definitely not my expertise, but I would say that what we have found with the collaboration with Fred Wu, who just had a very nice panel discussion in the previous session, and also Stelios Zaharoulis, is that radiation does help. So and it depends how you do it also, whether how many grays you're using and also how many sessions. at which point of the tumor size you're actually treating it. But definitely radiosensitizing, especially these very aggressive tumors that we have to deal with, would be the way to do it. So maybe start with radiation, aggressive treatment, and then switch to ultrasound, and then back to potentially radiation.
Okay. Greg, there is a question about timing of the ultrasound and radiation. Could you comment?
Yeah, I will. So in terms of timing of the ultrasound and radiation, in terms of long courses of radiotherapy or even 5-day courses of radiotherapy, we've sort of borrowed on what Kalervo said when we were starting this research, worked very well with hyperthermia, which was 2 treatments a week, which was done clinically with hyperthermia. And we found that to be a good balance between the enhancing effect and then any repair of the vasculature that needs to occur to allow you to treat with bubbles again. In terms of the timing, on individual days when you're giving the 2 modalities together, it doesn't seem to matter which one you give first. In very well-controlled animal experiments, the effect is the same whether you give focused ultrasound first or radiation first. Most of the work that we've published has had treatments immediately one after the other, but in terms of studies that we've done, it seems to be that the optimal separation of the 2, at least in test tubes and in animal experiments with verification of the ceramide metabolite, if you like, or the signaling molecule using mass spectroscopy from blood samples, seems to be 6 hours. So there's a maximal effect when you separate the 2 treatments by 6 hours. And that's also borne out in terms of when you go looking in the bloodstream of animals for some of the molecular intermediates of cell membrane stress, which are particular lipids and that molecule known as ceramide.
So thank you. That is interesting. Hong, do you have any comments on?
Yeah, I actually have a question for Greg. So Greg, you have been looking into this sensitization mechanism in different type of animal models. Do you foresee any challenge when we try this technique in DIPG, given that it's a different biology and different location compared with other studies you have done? So can you comment on that?
Yeah, so the mechanism is inherently linked to the vascular content of the target. So at least in different tumor types, the ones that are hypervascular potentially require more treatment. It all seems to be related to the number of, if you like, in a very simple-minded manner, the number of bubbles burst per unit length of vasculature. Separate from that, causing the vascular damage, there seems to be some sort of signaling that occurs to the tumor cells themselves. And so that's another factor to be taken into account. You have the activity of the native activity of the tumor cells in terms of their aggressiveness. The other thing that's actually very interesting and can be considered, especially when dealing with, for instance, DEFINITY bubbles or bubbles that have high nanobubble content, is that tumor cells themselves and all cells in the body also seem to respond via the ceramide pathway to membrane damage. And so you can perhaps even cause therapeutic effects with nanobubble content interacting with the target cells themselves. That's less explored, but it is a phenomenon that we noted. What makes the vasculature unique is that some of the key enzymes that make it very sensitive to doses of radiation and to the effects of, are the same ones that make it sensitive to the effects of bubbles. And those enzymes that detect cell damage seem to be enhanced 25-fold in endothelial cells compared to other cell types in the body. So, I mean, those are, on the biology side, things that will have to be carefully considered. On the physics side, I defer to the other people on this talk that have engineering expertise.
So maybe the final question on this topic from me. What do you think? You need to cause inertial cavitation, you need to cause vascular damage, or you can use just openable brain barrier, or even use milder exposure when you don't open the brain barrier?
So I think this is probably it relies on more inertial cavitation and actual bubble bursting than the opening of the blood-brain barrier, but it's not quite at the power levels where that people are using to enhance the delivery of chemotherapy and, if you like, to permeate the blood vessels. The type of dose seems to be such that the radiation effects on their own at 2 to 4 gray or even 5 gray cause ceramide accumulation, but on its own that dissipates and the vasculature heals. Here we're working in a realm where even though you cause perhaps some damage to the vasculature and you cause ceramide signaling on its own with the focused ultrasound, by 72 hours the effects are gone and the vasculature is back to the way it was, and any damage that was caused is repaired. So it's sort of probably a realm in between blood-brain barrier opening and the, if you like, the harsher treatments.
That's interesting. So Elisa, maybe you can tell us about the blood-brain barrier opening. How much more work needs to be done with your system that, to be able to do it routinely and very precisely, and be sure that you are getting enough opening and enough drug delivery and not too much.
So I have to say that I've been pleasantly surprised how it has been working so far. Given, as I mentioned in the talk, how, we don't go from the top like the logo of this workshop, we go from the back. And obviously the reason being that the pons are right here, and we didn't want to lose a lot of the energy of the beam, especially with attenuation. And I'm going to talk a little bit about the layering back here. It's not just the skull. So we have nevertheless been able to cause opening. And in almost every sonication that we've done, almost 24 sonications, and safely. So this is a big underline, of course, because we're doing it very, very 3 times a week, every 2 days, which is in the beginning, I was mortified as an engineer. We haven't had that type of aggressive treatment in our mice, but of course reassured by the physicians, Fred Wu and Sergio Zaharoulis, that this is the only way that the treatment can mean something. And the FDA actually required that of us. They said, you're never going to treat this tumor just by, once a week. This is not going to cut it. You have to be aggressive. So we overcame a lot of our comfort zone, and we did open. Although if you put the transducer vertically in the back, everybody knows that it's you have to beat gravity, which as a physicist, right? Nobody wants to do that because it's impossible. So long story short, there are ways to stabilize the gel and be able to have coupling. The muscle back here, the skull, as we know, is the thickest, right? But the muscle in this, some of the kids, because they are debilitated because of the disease, right? And they also are on steroids. So this means that they could be even more bloated. So it's not just the skull, as I was saying, it's also the muscle and the fat layer, and that we have seen through simulations that causes further attenuation, especially with the bubbles going there. And we can also see cavitation on the muscle and sometimes on the skin as well. So all this, and then of course it displaces your focus. So it's very important when we plan these treatments that we don't ignore the muscle, we don't ignore also the fat layer, the skin layer that may displace the focus. But we have been able, as I said, to do this very nicely focused in the pons. I know the 250 kilohertz is a long focus spot, like Kullerva showed, and this is what the simulations predict. We never have this big of an opening. It's much more focused. As we know, this also varies with the white matter and the overall attenuation in the brain. And we have seen some very, very initial results of having a beneficial nature in the locomotor of this pediatric patient, so they can move the contralateral side of where we treated a little more freely. So now we're looking at a potential neuronal benefit of reducing disease, especially on the diffuse side.
Thank you. Hong, what do you think about the treatment? And
yeah, I have to rely on Alisa to share the wisdom regarding the clinical studies. So for the small animal studies and the large animal studies that we have been doing, I think it is DIPG, the unique location does pose challenges. So I have to say, I admire Alisa so much being so brave to move forward with the clinical trial. And we have been doing mouse study and then recently started with pig study targeting the brainstem area. And we do cause hemorrhage at the bottom of the brainstem. I think that also connect with Clara was mentioned earlier. The brainstem is located right above the skull base, so there's a strong reflection of acoustic energy there. So we did cause hemorrhage. So we're still trying to figure out what is the optimal parameter even for the pig model. So definitely I also want to get Alisa's suggestions regarding how you choose the parameters so you feel comfortable regarding the safety aspect.
So can I quickly respond, Clara? Yes. Okay. Yeah. So very quickly. So two things that we may have gotten away. So when we do from the top that we do in Alzheimer's, we do get standing waves in the simulations, right? Because you hit the bone on the other side. When we go from the back, we have the longest axis of the brain. So we don't, at least we don't see any hemorrhage, and we have gone very, very low in the beginning to the point where we were not, the first couple of times the opening, our radiologist said there's no opening. Our attenuation we predicted was 65%, and it was not a good prediction. It was, again, when we added the muscle and some other layers, we went to 85%. And this seems to be also with monitoring and especially mapping. It's also where you see your focus during mapping, because obviously, detection gets you to see whether you have inertial cavitation or stable cavitation, but it doesn't really tell you where you're having it. So that could be something that you could potentially see whether you're detecting cavitation at further down from the focus, and that could be some sign of damage. So mapping is definitely feasible. So that's also something that we found more recently.
Good. So interesting discussion. Let's talk a little bit about, we have only a few minutes, so a little bit about the sonodynamic therapy. So the results are very encouraging for multiple groups now, including ours. And so that would be maybe ideal way of treating, because you don't need bubbles. But what would be the hurdles? Hong, can you imagine using sonodynamic therapy? What are the challenges that we would face there?
Yeah, I have to say this is an area I haven't studied enough to make any reasonable comments. I'm going to pass this opportunity to others.
Elise, any comments from you?
I think we should definitely look at that. These tumors, and like any tumors, I would say in the body, but because we do a little bit of pancreatic, breast, and all that. But obviously, this tumor specifically needs everything and then some. So I would definitely say sonodynamic therapy, blood-brain opening, the drug delivery, and radiation, or different drugs, and whatever it takes. I don't think it's going to be one technology, and if we, one technique specifically, and if we can also see how we can combine that as part of this workshop, what should come first. If it doesn't matter, then just having a series of treatments, because it's, in the end you're going to need a beam. If the beam is already there, sometimes you don't need the bubble, sometimes you don't need the drugs, or you need specific radiosensitization. So let's it doesn't have to be one or the other. And I think in the end, all of them have to be combined. But I would also add what was brought up also in this panel and the previous one, that you need to monitor the tumor response. We work very, very blindly with just, oh, you know, fingers crossed, let's see the tumor volume in a couple of, you know, weeks or something, or sometimes months. I think that what was brought up about vasculature, we can map the vasculature of the actual tumor. We can also map the elasticity. People have shown that mapping the stiffness of the tumor, including from our group, that it potentially shows whether it's responding or not. It could be some regions of the tumor that are less vascular or have lower interstitial fluid pressure, or even the diffuse disease. It's a very, very complex tumor, as we know. So we have to monitor it closely and hit it where it hurts, literally.
Great. What about your? Yes.
Are you asking me? Sorry.
Asking Greg.
Oh.
Muted.
Yeah. So I guess it depends on what the molecular mechanism is that going to be that the photodynamic therapy actually initiates. What's the carrier or the chemical reaction that's being caused by sound interacting with the agent in and around the tumor? So I think there's a lot of questions there. Certainly, it's another way to stress a cell. And in particular, in terms of basic principles of, for instance, chemotherapy and oncology, are that you use multiple agents with different mechanisms to achieve synergistic effect. So certainly very promising, and sticks to the principles of, like Elisa said, hitting the target in many different ways for optimal effect.
Okay, so I think those were good comments. Anything else you would like to say before we open for questions? Anybody has any? I think technically this is quite challenging. The challenge is that we need to do it safely and we need to do it effectively. So there are many examples in the literature where therapy is potentially effective, but this has not been effectively used, including like hyperthermia. Suboptimal use killed the whole field. Okay, I think we are ready for questions. Lauren, if you have any, do you have any questions?
So I think a lot of the questions that have been asked in the chat so far have been answered fairly adequately so far. So thank you for being aware of that. So now to everyone else who is on the call, if you have any questions, please just raise your hand and turn on your camera and we will call on you. It looks like Mehmet has a question, so go for it.
Yeah, sorry, I couldn't raise my hand somehow. So, I also, I know your study in 2019, I think, and then this new one I didn't know, of course. And what are the major differences? So the frequency has changed, and I think in the new study, the drug concentration is a lot higher, 60 milligram per kilogram, I guess. Is this achievable in humans, or this could be actually applied in humans? Yeah.
So that's a good question, Senkai. What do you think? Can it be achieved?
Can everybody hear me?
Yes.
Yes. So we use for every treatment we use the same drug dose, but we just repeat it 3 times. So it's so I think the power intensity is actually lower, and we use a lower half megahertz frequency. That's the main change. But the drug dose and sonication parameters is actually lower.
Mm-hmm.
Yeah.
And in the clinic, I think they do like 10 milligram or 15 milligram per kilogram in the clinic of 5-ALA administration. Have you tried any dose, with SDD within the animals, like 15 milligram per kilogram?
No, we haven't tried try to change the drug dose, but from their reaction after treatment, I think that's tolerable.
And do you see any abnormal physiology in the animal with 60 milligram per kilogram of 5-ALA?
No. So the drug is quite irritating, so you have to inject slowly. Yeah, over like maybe a minute. Yeah.
Okay. Thank you so much. Great.
I think in the next session, maybe Dr. Marcus can answer some of those.
Yeah.
Lauren, any other questions?
It looks like Susie just posed a question about clarifying whether or not the head needs to be shaved. I think that's probably for Dr. Konofagu. And then anyone else who can comment on sort of along those lines, just the differences between a pediatric patient and, you know, our more, what we're more used to, which is the adult patient in terms of things we need to consider going forward.
Yeah, I'm obviously too slow because Fred is on fire answering the questions. So obviously for kids, there are two issues. One, they don't want to lose their hair. They don't want to go to school and, you know, show like everybody else for that matter, but especially for kids that they're sick. So we are basically looking, we only shave, in this case, the back of the head, where the footprint of the transducer we go, especially for girls, you know, they have long hair and they can just cover it. For boys, it may be more difficult, but some boys like to also have the shaved, the back of the head. So that's definitely something that we do. We don't require full shaving at all, even for our other patients. The second part is that the kids come, as I said, 3 times a week. Putting them in an MRI scanner 3 times a week, it's cumbersome. It's a long time in the magnet. Also, the fact that they need to be immobilized. So that's something that we don't require anesthesia at all. And parents are really happy about that. This is something that keeps patients coming, and the parents bring them to Columbia. The fact that we don't have to shave the hair or perform anesthesia. They can be immobilized for 2 minutes, and the whole procedure takes, right now, from start to finish, 30 minutes.
The Insightec device should be able to use it with short hair, so it doesn't need to be saved for this kind of experiments or treatment. For ablation, probably have to be saved, but for blood-brain barrier should be okay. And for sonoplanate therapy, probably don't need to be saved. Same with radiosensitization, probably can go to the hair without any difficulty.
Thank you. Any other questions? Yes, Sabine.
Could you comment, I mean, in terms of, I mean, I think, Elisa, what you had mentioned, right? I mean, I think the feasibility for children, right, with frequent sedation, pinning of the head, I think is really for the clinical trial development a challenge. What are sort of prospects in alleviating this for some of the commercial devices? Does anybody know? Are there plans to make this that you don't have to shave your head and that you don't have to be immobilized?
The saving of the hair, I think we are starting a trial with that. So on blood-brain barrier opening with immobilization devices, there are several approaches people are using around the world.
Yeah, for immobilization with radiation, as you know, some of the newer gamma knife systems don't require pins anymore. And in fact, they've gone to a frameless technology. So there's no reason why something like that could not be considered in principle for focused ultrasound in the future.
So we also don't use a frame. I mean, we have, right now we have different renditions of what we're doing, but the latest one is that they rest their head on a kind of a massage chair, and they have an iPad in front of them, and we come from the back, so they're completely relaxed and immobilized for the 2 minutes that we sonicate. So that has been, so far, I think something we're sticking with, but we try to make it comfortable for them without a frame.
So Elisa, do you give a separate dose of bubbles every time you sonicate, or do you do multiple sonications?
So we do one sonication every session. So new bubbles every time. Yes. Yes.
So there was a question in the previous session about sonicating the whole volume. That is feasible, definitely, with current devices. The Insightec device can electronically scan the beam, and we are treating large enough volumes in patients that would cover the whole target area in these cases. And animals, we have done whole brains, and dogs half brains, so it is feasible.
Yeah, it's important to treat as much as possible. Obviously, making sure that it's safe. But we have this robotic arm that can sweep across the pons. I mean, this is something that we haven't used because the FDA allowed us to do a single sonication each time. But we envision that for the continuation of the trial, should we be approved to continue with more subjects, that we can sweep it during circulation of the bubbles and cover a big part of the pons. There's also lensing that we can use to bypass the skull and generate a much bigger region. But as Fred is saying in the chat, in animals we treat the whole brain stem, and we have found that is safe, and it also has the highest efficacy.
I do have one more question. Clara, did you have one coming?
No, I'm just asking any more questions.
Okay, yeah. So one final question before we wrap up, and it's for Hong, actually. When I was watching your pre-recorded presentation, and you spoke about how you had a couple of studies where there was no response, can you speak a little bit more on what you think that was all about? Do you guys have any hypotheses as to why you didn't see a change in tumor response after focused ultrasound therapy?
So I can you clarify specifically? Well, after what part of the treatment?
So sorry, I can try. Oh, actually, you know what? I'm confusing. It was actually Dr. Ozda's presentation. I'm so sorry. So Mehmet, I know you're here still. Can you clarify? I apologize about that. Why you think you didn't see a response?
I'm sorry, I didn't follow the question first. Could you please repeat?
So in some of the preclinical work that you spoke about, you said that there was no response with the drugs tested, even though you saw an increase in concentration with the blood-brain barrier opening.
Yeah, in these two studies, so one was from Colombia and one was from Toronto. I think so. There could be like 2-3 reasons. One, maybe these molecules are large enough, and when you open BBB, you can maybe achieve 2-3 times more concentration. But with systemic administration, maybe it's very, very small, and having this like 2-3 times more, maybe it's not enough. So this could be one reason. Maybe we need to have a lot more, like maybe 100 times or 1,000 times, than compared to systemic administration. Or maybe because the tumor microenvironment is very different, and if that has a lot of like pressure from outside the vessels, this could also eliminate the diffusion of the drug from inside a capillary to outside. This could be a different reason, and the drug itself could be a problem there. I mean, they show that, like, at least from the James Rutkal paper, they show that in vitro, the drug is able to kill. But maybe in vivo, it's not, they're not able to achieve that much concentration in vivo. I hope it's more clear now.
I think, Lauren, right, Dennis had addressed this also in the first session, that it's really potentially right, the PK/PD effect. So I think in terms of a translation into the clinic, and we will get to this also after the break, I think there's still a lot, right, in terms of choosing the right drug and what is really the right PK profile of a drug that then will work well with the first. So I think that there's a lot of still unknowns here.
We will now move to the clinical portion of this workshop. I want to thank Sabine Mueller and Sergio Sakaroulis for moderating this session, along with our panelists. So if I could have Tabitha Cooney, Lindsay Kilburn, Carl Koshman, Stuart Marcus, and Fred Wu turn on your cameras and unmute. I believe that either Sergio or Sabine is going to start us off with a summary of the pre-recordings, and then we will move to the panel discussion. Thanks for rejoining us.
Yeah, thank you, everyone. We are obviously very excited for the translation into the clinic. So I will summarize some of the content that was posted prior to the workshop, and then Sturgis will go into more really an overview of active clinical trials. And then we'll also introduce our panel members, and we are very thankful that they're taking their time today before we then move into the discussion. So we heard a little bit about sonodynamic therapy in the earlier discussion presented by Javad. So what we heard is that protoporphyrin can serve as a fluorescence marker as well as a therapeutic vital photodynamic therapy. What we learned from Dr. Marcus's pre-recorded presentation, that it shows promising outcomes in a single center study of glioblastomas, which had included a total of 60 patients. But at that time, the setup was quite complex and it was challenging to move this forward. And maybe we can go into this a little bit further in our discussion later, but that it still provides a great opportunity to move this potentially forward using ultrasound. And so there's currently the Sonala 001. It's an ongoing controlled phase 01 study in recurrent GBM patients. And it's basically a study that is escalating the energy dose. So patients receive 5 ALL and cohorts are escalated to 200, 400, and 800. And sonication is applied to only 50% of the tumor volume, which is actually a really great design so that you have an internal control and you can look at the tumor resection in the treated versus untreated area. And then after the application, patients undergo resection of a recurrent GBM, which is performed about 4 days post the sonication. And the primary outcome of that study is safety. And so what Dr. Marcus had outlined is his trial, and I'm sure he can elaborate on this a little bit later in the discussion as well. So a total of 5 patients have been treated. You see here with different dose levels. There was only 1 minor adverse event reported. There were no greater 3 events or serious adverse events. And when they looked at the tumor tissue, there was significant increase in sort of the oxidative stress and apoptosis in the treated compared to the control side. And I think that study is ongoing and enrolling, but obviously is sort of the first study really proving that this photodynamic therapy can be beneficial and especially also safely applied to adult patients with recurrent GBM. And so based on some of the preclinical data we heard earlier this morning, but also this ongoing adult trial where initial safety is being assessed, but it looks very promising. A multi-site trial of that similar strategy is planned for diffuse pontine gliomas. There is an escalation of 5 ALL as well as energy. And again, the idea is to treat 50% of the pontine volume at baseline, and then the second half at 30 days. The primary endpoints of a planned study is safety and to establish sort of a recommended phase 2 dose of what we would want to move forward in a larger study. And then secondary endpoints include objective response, PK, progression-free survival, duration of response, and overall survival. The other topic, which I think is of great interest when we are thinking about focused ultrasound, is really how to potentially combine it also with immunotherapy. So there's a great presentation from Dr. Hideo Okada from UCSF. If you haven't had a chance to view his presentation, please go to the website. But overall, the summary from this is that within DIPGs, there has been now several publications showing that within the immune microenvironment of DIPGs, that they have fewer T cells and less inflammatory myeloid cells compared to adult GBM, that they don't really show this increase in macrophages or T cell infiltration relative to non-tumor control brain. And we had addressed this also in the first session a little bit, that obviously there is now really the evidence, and we knew this a long time clinically also, that the blood-brain barrier is intact in DIPGs. And so when we think about immunotherapy, so what is known and what was really nicely summarized in Dr. Okada's presentation is that T cell extravasation across the blood-brain barrier during healthy and non-inflammatory states, that there is a difference. And so without inflammation, T cells are mainly located in the perivascular space. But then in an inflammatory state or in the presence of antigen-presenting cells, activated T cell can cross across the second layer of the BBB, and that is often mediated by MMP2 or MMP9. And to really do that successfully, T cells need to be arrested via interaction with adhesion molecules. And I think we have to really think about this process quite carefully as we think about translating potential combinations with focused ultrasound and immunotherapy into clinical trials. The other point that was brought up also in the second session and also in the first session already is how to best monitor for response. And I think that is an ongoing challenge we have in diffuse midline glioma trials. I mean, our standard, as you all know, is basically serial MRI imaging, but there's really challenges to differentiate between pseudo progression versus true progression. And it's not the ideal method, but it's the one which has obviously been integrated so far in all our clinical trials. Dr. Korschmann pre-recorded a lecture about how we could potentially think about using liquid biopsy for monitoring of responses, and this is now integrated in many ongoing trials, including some of our PNOC trials also, where serial plasma and CSF is being collected, and we have demonstrated, and that has been shown by multiple groups, that you can detect especially by H3.3 mutation, and you can quantify this. And what Dr. Korschmann has been able to show that the allele fraction change over time, if that's declining, that this is associated with sustained progression-free survival in the CSF. There was a bigger change, but also present in the plasma. And what he was always also able to show is that sort of if you have a spike in the H3.3 K27M cell-free DNA, that potentially precedes really tumor progression. I think all these associations are not perfect for every individual patient, but overall, I think we see a great trend. And that assessment has the potential to differentiate progression from pseudo-progression. And then he and his team are currently developing additional potential sequencing methodologies that can enhance our assessment of potential tumor DNA so that we can use it to assess responses. So with that, I will end and hand it over to Sturgios.
All right, so thank you, Sabine, and thank you. I would like to thank also the Focused Ultrasound Foundation for organizing this wonderful symposium. So what I'm going to do first, I'm going to, just for the benefit of people who didn't have the chance to look at the educational part, just briefly summarize our study and also give an overview of where we stand with active clinical trials in DIPG and see how all this fits in the discussion we have right now. So with the help and support and all the fantastic science that Dr. Konofagu presented earlier from our biomedical engineering department, and in collaboration with Fred Wu, who also presented earlier, our radiation oncologist, we developed a clinical study for patients with relapsed DIPG using Elisa's device, which is non-invasive for an ultrasound, and it has all these components that were described earlier. And we started this trial where we wanted to examine the feasibility of non-invasive focused ultrasound with oral panobinostat. This is primarily a feasibility study for maximum 15 patients. And the primary objective was to evaluate the safety of and the feasibility of using the focused ultrasound, particularly this device, to open the blood-brain barrier in multiple tumor sites. And this is like a dose, quote-unquote, escalation from 1 to 3 tumor sites. The secondary endpoints were to evaluate by imaging the changes in the blood-brain barrier. And we incorporated also evaluation of cell-free DNA, and of course the survivals. So what this study is about, so we have patients with progressive diffuse pontine glioma or diffuse midline glioma. And for these patients, we administer the sonication in the radiation oncology unit. And then right after that with microbubbles. And right after that, we will give them immediately after a dose of oral panobinostat every Monday, Wednesday, Friday, 2 weeks on, 1 week off for 6 cycles. And what we do is we, in the every other cycle, we evaluate with imaging Monday and Wednesday, the opening of the blood-brain barrier within 2 to 4 hours and the closure of it within 36 hours or so. So the patient comes on Wednesday, we confirm that the blood-brain barrier or where we aim to open is practically closed. So we determine that. And then we continue on with the sonications. So the study opened a few months ago in the midst of COVID. And we have treated so far 3 patients. The ages range, as you see, 10, 14, 18 years of age. They are about a year post-diagnosis, most of them, as expected to progress, and they were all proven H3K27 mutant positive diffuse midline gliomas, and 2 of these 3 patients had re-radiation. So far, we did not see any severe adverse events. They had very mild toxicities with vomiting and diarrhea. 1 patient, unfortunately, in between treatment developed COVID. And despite that, we carried on with panobinostat without the sonications. The interesting thing is that 2 of 3 of these patients had some clinical improvement with a physical examination. 1 of them specifically with unequivocal left-sided improvement in her strength. So the follow-up remains short, and we are about to start 2 more patients next week. This is an example of the imaging where you can see on the top part the changes in the flare and the contrast. There's a tiny area where we see the opening using the sonication. These are MRIs that are obtained within a couple of hours from the sonication and then being repeated 2 days later to confirm the closure. You can see both the flare changes and the contrast and enhancement changes. So we just started. There's not much more to say about the trial right now. But when we think about the trials right now that are active in terms of the open and recruiting, this is the landscape of the, to remind everybody, I know you're all experts in this disease, but just to recap, we have systemic therapies, which are targeted therapies and immunotherapies. The targeted therapies primarily, as you see, some of these drugs are very specific for DIPGs, such as the ONC201, the ONC206, the fimepinostat with the panobinostat that are HDAC inhibitors. There are c-MET inhibitors as well included in the studies, STAT3 inhibitors. In terms of immunotherapy, other than the trial that was just presented, there is the opening of that previous vaccine study with nivolumab. monoclonal antibody against CD40. There's the PD-1, new generation PD-1 inhibitors that are being tested, systemic GT2 CAR T cells, and Intoximod, an IDO inhibitor. Now, in terms of local delivery, we have the conventional enhanced delivery from one that was completed from UCSF, and a similar one with a different mode of delivery that we do here at Columbia with MTX-110, which is the water-soluble panobinostat. And the Memorial Sloan Kettering team is doing the oturmumab. Of course, there is also the immunotherapy with CAR T cells with local delivery with Veledmex to facilitate immunotherapy. So that's where we stand. From these drugs with the targeted therapies, you probably will notice that some of them have specificity for DIPG, some of them not as much specificity in terms of the preclinical background and the rationale. Some of them have variable CNS penetration, some of them have adequate CNS penetration. And the big question that we would like to discuss with the panel and all of you is where focused ultrasound can be, what is the role of a focused ultrasound in the future of this studies, provided that they give positive signals. So with this, I would like to introduce our panelists, namely Lindsay Kilburn from Genders National, Stuart Marcus, the CEO from Sonolens, Fred Wu from Columbia, our radiation oncologist, and of course, you know Sabine already. Maybe Sabine, we can kick off with the initial discussion.
Yeah, no, thank you. I think it's obviously very exciting to see how this is moving forward. And I mean, we've heard a lot about the Sonolens trial also, and I mean, there was a big discussion in the preclinical work. Maybe, and I don't think we dwell too much into this, and that goes to sort of session one panelist, but also maybe to Dr. Marcus Yu. The preclinical evidence moving this forward for DIPG, is there any comment around this? There's obviously great data in the GBM models, and then there's obviously exciting early phase data from the adult recurrent trial. Because I think it's one of the discussions, right? When we move things forward into the clinic, is there sort of a set of experiments we would like to see, before we move something forward for our children with DIPG? Just open up the floor to anyone who wants to comment and educate all of us. Yeah, Dr. Marcus. Do you wanna?
Thank you. Can you hear me?
Yeah, now we can, yeah.
Okay, good. First of all, I want to clarify that the study that we reported on, Dr. Sinai, Nada Sinai of the Ivy Brain Tumor Center, is my co-author for this presentation. And it is also the Ivy Brain Tumor Center's independent study. It's not a Sonolens sponsored study, but we are collaborating. It is the Ivy Brain Tumor Center's IND and Dr. Sinai's IND, which we are grateful for collaboration. And so I think preclinical data is always so important. And one of the questions that people have asked in the preclinical section is, are there any data supporting the accumulation of protoporphyrin in the DIPG cells? And Sonolens has been collaborating with Javad Nazarian's laboratory since January. I'd like to not get the jump on him, but I'd like to ask Dr. Nazarian if he would care to comment on preclinical work that we have been collaborating on since January of this year. Javad?
Sure, of course. So you have seen some of the data for accumulation of 5-ALA in the rat cells and the publication of the in vivo efficacy. We have done this in DMG cells, and in all of the DMG cells that we have tested, the accumulation of PPIX in DMG cells is so much higher than in rat cells. So initially we used rat C6 gliomas as the control to see if the drug works, but the accumulation is so much higher in DMG cells. But more importantly, also the tendency of the cells to retain 5-ALA and to continue to build PPIX is really long, over more than 24 hours after treatment with 5-ALA. The DMG cells pick up the 5-ALA and they continue producing PPIX. Even after if you wash the cells within 2 hours of exposure. So in vitro, we have seen that they do pick up 5-ALA. They're very sensitive to the drug and to conversion into the PPIX.
Thank you, Jovan. So just to finish my comment, that data, those data are extremely important to support our sonodynamic therapy trial, SDT-201, which the FDA has just given us permission to proceed with all 3 sites, including yours, Sabine, which I'm very honored to include, and Dr. Kilborn and Dr. Packer, of course, in the site. So we're very excited that the preclinical data does support that. And I think sonodynamic therapy, we're extremely excited and that we finally have supporting data that the drug is accumulated in DIPG cells. And of course, we're very cautious. We're only going to treat half of the brainstem, half of the pons in the first patient, followed by a 30-day safety period, after which we'll treat the second half. If the first 1 or 2 patients show that they have no adverse events after that, the next patients we will treat the entire pons at the single treatment in order to maximize the therapeutic effect in SDT-201. So thank you for asking.
And I think it did also come up, in the discussions earlier, right? The treatment of a primary tumor volume versus the surrounding area, right? I think that is an unanswered question. I think for all these more local delivery strategies, also what Sturgios has mentioned for convection enhanced delivery, right? How we can overcome sort of some of the limitations when we're using a more directed therapy to the surrounding. Any from Lindsay or anyone, any thoughts on that in terms of a clinical implementation and how to solve that issue?
Yeah, I mean, I think it's a good question. We've obviously had ongoing discussions about, and certainly I think as some patients do live longer, we're starting to see kind of more and more development of metastatic disease sites or further extension kind of beyond the pons. But the reality is that most patients still die of progression of their disease in the pons. So I think that is something that we'll need to address and think about addressing. But obviously, focused ultrasound is a therapy that could be given to other areas potentially. So if we're seeing improved efficacy in the pons, but I do think the volume will be important. And I think when we're thinking about treating will be important. So, I think we often see that leading edge is kind of an area of progression at the time that patients progress, but perhaps if we're using these interventions earlier in treatment, either post-radiation or things like that, then maybe, as we kind of establish the safety, we can kind of expand the target into the kind of cerebellar peduncle or, beyond slightly the margins of the tumor or things like that. But I think obviously we're early in the development and need to first establish the safety. And obviously if we can control the local disease, I mean, that would be a huge step in the right direction in terms of caring for our patients.
And I guess the big question is in relation to sonodynamic therapy. With my little understanding of this is that the concept and the rationale and the mechanism of action is quite different from the ultrasound that we use to open the blood-brain barrier. It's one is an apoptotic mechanism, the other one is to disrupt the barrier to increase the concentrations of an effective drug. Do you think that we will have data, safety or efficacy data that can go from one concept to the other? For example, our opening is extremely small, is tiny, and the attempted trial with the sonication therapy is planned to cover half of the pons and eventually all of it. But the safety of this study, I'm not sure whether it necessarily can be translated into allowing, for example, our type of approach to move forward that aggressively.
If I may, sorry, Fred, right on here, if I may add, I think right now there's a huge gap in terms of what's desired versus what technology can do. You know, with the radiation, whether it's Insight Tech or other devices, you know, they're not like radiation, whether it be like the gamma knife or whatnot, where it's a constant source of cobalt or whatever that's delivering the radiation. The blood-brain barrier requires the timing of the microbubbles, at least for drug delivery's sake. And that's really the biggest limitation, mainly because, you know, we are giving the microbubble as per radiology, you know, FDA approval, which is in bolus form. And so it does have a run out. You have a finite time, and in a day, you can only give it twice. So even if we can give multiple focus, which is part of our trial to figure out if we can, you're still limited by just that 2 bolus of microbubbles, and you're limited by that volumetrics. So really, you know, there's a few things that I think needs to be addressed in terms of volume and opening and the feasibility of delivery. One is from the microbubbles itself. You know, we clearly need a microbubble delivery that's suitable for blood-brain barrier opening, whether it be continuous infusion or something else. You know, that's super important. The second part is technology. So somehow you need to give technology that allows you to open a set volume. You know, it could be either via the implantable device where they implant multiple transducers in the skull. Now, clearly that's one strategy. It opens a volumetric, but you can't control in terms of where it goes and how much you do. You know, other strategies include using, you know, multiple arrays where you can shield off certain areas and give different volumes. That's another strategy. And the third strategy that we're excited about is what Dr. Konofagu had alluded to a little earlier about this concept of acoustic holograms. So to me, I really like that idea because it's very similar to radiation. You know, it's this concept of compensator. So if you're delivering sound to a depth and you know a shape or a target that you want, you can 3D print something that blocks the sound speed at a certain level. So at the target of where you're going to, you may be able to cover volume. So we've been doing some work in terms of modeling to create, you know, homogeneous plans to cover brainstem and volume. I think that is to me is a strategy I can bear my brain around because it's really similar to radiation treatment in terms of what we do.
Yes.
Yep.
Yes, sir, we can hear you.
Oh. So I just wanted to point out about something about some and it's based 15-year history of ALA photodynamic therapy in glioblastoma, which was started by Walter Stummer who began the fluorescent work. And the important thing about photodynamic therapy as opposed to blood-brain barrier opening is that it is an immediate effect on the molecule in the tumor, which generates singular oxygen only within the tumor, which makes it, number one, very safe because of the selectivity. ALA fluorescence in glioblastoma is a 98% positive predictive value that fluorescent material is glioblastoma. That's the highest specificity of any chemotherapeutic agent, number one. Number two, in both the animal systems and the work that Dr. Sinai, in collaboration with us, has been able to duplicate, it's important that the results he has seen are after a single treatment. In 4 days after treatment, you're able to demonstrate significant apoptosis and cell death and changes. So one of the good things, and ALA accumulation in glioblastoma doesn't change with recurrence, the first, second, third, or fourth recurrence, because it is a metabolic requirement. So what we're doing is turning the metabolism of the glioma cell against itself. It needs ALA, and we are giving it lots of ALA, which forces it to accumulate. So those are things that I think distinguish it from blood-brain barrier opening, which is essentially a drug delivery system. Sonodynamic therapy is an entire new kind of therapy that's a non-invasive, rapid, effective, and extremely restricted to the tumor based on what we know about the fluorescent data in CNS tumors today.
Yeah, no, I think that's a good point, but I also think what the point I think Sturgio's made, right, can we translate any of the safety from each other? That might not be necessarily the case, right? But I do think in terms of feasibility and everything, I think there's still some crosstalk that could enrich each development, right? Either if you use it for really activation of your medication, like in sonodynamic therapy, or if you use it to open up the blood-brain barrier. So it will be interesting to see how what we can really cross-learn from these trials and inform each other. I wanted to maybe, Carl, you know, I mean, you obviously had your really nice pre-recording. I mean, anything you wanted to add how we think about monitoring, right? And I think that really goes to the BB opening. What is really I mean, we talked about in the preclinical session a little bit, right, that labeling of a drug and directly imaging would be great. But could you maybe just give your viewpoint where you think this whole evaluation of cell-free DNA and where this is going, and if there's anything we should incorporate early into these trials now, or even collection of specimens so that we start learning rapidly?
Sure. Yeah. My name's Carl. So I am just one of the physician scientists at University of Michigan and mostly focused on DIPG and DMG. And as Sabina said, part of our research here is on correlate markers of response. We've treated a lot of children at U of M on ONC201 and a couple other targeted therapies where we've enacted this more progressive monitoring protocol where we will obtain spinal fluid alongside MRI at certain time points after initiating therapy, as well as plasma collection. And then our lab has done a fair amount of work of collecting the plasma and spinal fluid samples and assessing primarily for the histone mutation in cell-free tumor DNA, both in spinal fluid and plasma, and then tracking that over time. And so that's some of the work that I put on, as Sabina mentioned, on that, the pre-recorded panel. If you're interested, you can look a little bit more. But the short answer is, we think that there's a lot to be found in the cell-free tumor DNA. You know, we've been focused on histone mutations, but you can also find other patient-specific mutations. That data is mostly enriched in the spinal fluid. And we do think that there's really a good reason to continue to collect those prospectively, despite a little bit of extra risk and logistical issues related to that. But in the PNOC trials that we've been designing with Sabina, we've been implementing those as long as it's, you know, the local clinician feels that it's safe to collect spinal fluid. What we found is that what's interesting is that the allele fraction, the mutation amount of the amount of mutant K27M versus wild type does seem to be telling stories about the tumor response. And oftentimes it doesn't track exactly with the tumor area, but we've have a lot of cases where it spiked up, you know, in 2 to 3 months prior to the tumor growing, or in a couple cases where the tumor was growing and we later found that out to be swelling related to radiation and not progression. We didn't see that spike in the cell-free allele fraction. And so, you know, I really do think that right now it's on the research setting, but in years and definitely 5 to 10 years from now, spinal fluid and hopefully eventually plasma alone will be able to give us just an extra metric. It's not going to replace MRI, obviously, but it'll be an extra metric. And we're starting to look at other research metrics beyond DNA. So looking at nucleosomes, the protein that you find in the spinal fluid, as well as mitochondrial DNA, which is obviously very important for these metabolic targeting drugs like ONC201. So, you know, a lot to be said here. I can probably stop talking, and see if that spurs on any other questions or comments.
Thank you, Carl. The interesting thing is that in the focused ultrasound glioma literature, in preclinical work, there is documented that the use of focused ultrasound can allow identification like 5,000 times more of cell-free DNA, which on one way is excellent in terms of biomarker, but on the other hand, raises us concerns about the potential of causing metastatic disease. Because of course, this is the cell-free DNA, but we don't know what happens at the cellular level, etc. So I don't know if you have any comment on that.
Yeah, I mean, it does raise an interesting question. And my own instinct with these midline glioma cells is that no amount of local disruption will really change the biology or it's not, I wouldn't think of it in terms of tumor spillage. I think these are cells that really require the midline microenvironment to take off. And it takes a genetic change in these cells to switch to more of a leptomeningeal model. And so I would be less concerned about that. Obviously, there's more research to be done there because we're in new territory here where we might be disrupting the tumor enough to think about that. But, I guess the other interesting point is, if we're tracking tumor DNA and you have a therapy that's actually disrupting and increasing it, how does that change our ability to track tumor DNA? And what we've found in preclinical models using radiation, which definitely lyses the cells and stirs up that tumor DNA, is that there's a brief spike followed by a washout. And the spinal fluid is washed out multiple times in a day, to my understanding. And so I think that those changes that you might see acutely after something like an ultrasound guided therapy would not persist, in the weeks to months after, and you could still continue to get these measurements and hopefully make some sense of them.
Carl, I've thought about this as well, and kind of the timing, similar question. I think if we think about utilizing cell-free DNA, either CSF or blood or both, ideally, potentially, the timing of when those samples are drawn is relative to the ultrasound is really going to be critical and informative, potentially informative, but maybe different than the controls that we have, when we haven't been using focused ultrasound. So I think as we build these trials, thinking about how to best time those studies, realistically from a patient perspective, will be important. And I think we may need additional time points that obviously is easier done in the blood than in the CSF to try to see if we see changes that are kind of, temporally associated with the focused ultrasound and or what it is that's kind of reflective of later response. Obviously, that's going to take a lot of time to accrue the information and the data to be able to really make sense of it. But I think if we don't start from the beginning to collect that, it's going to take a long time to figure that out. Do you have thoughts on kind of what you would say you think is a good starting point for these studies?
Yeah, I think to your point, and maybe to everyone's point, we probably need more data, right? We need more like daily level data to be able to really answer these questions about what would be the ideal time points. If you're doing it by lumbar puncture, I don't know that we can really comfortably or ethically suggest more than every time you're doing a sedated MRI. And even that, I think, is a sort of a comfort level for some clinicians and families. What in talking with some neurosurgeons, we dance around this idea of placing Omiyas for therapeutic reasons. But the neurosurgeons that I've talked to said this is really a pretty safe procedure. It's sort of the neurosurgical equivalent of a portocatheter from a sort of technical complexity. And I may be oversimplifying it here, but I think if we could get our heads around whether, this would be ethically appropriate and then figure out the IRB related language and how we would discuss this with families, the way we could really tackle the questions you're asking about, Lindsay, would be to get an Omiya and then really much more frequently collect from it. Being able to pull from the Omiya without sedation for some of the older kids. And then we could learn what are the best times to collect this, does it help to do it more often than, monthly, as well as maybe there's something to be said for how much that spike is in the initial week is maybe predictive of how well your patient's going to respond, right? So that sort of early flare in tumor DNA might be helpful. And we have no idea because we definitely don't collect more often than every 2 months from so far.
I think, Carl, that's a great point. And I think, the CAR T cell, right? I mean, obviously, Vilmaya there is used also to give therapy, but they obviously now have a chance to collect much more frequently. And it seems like that overall, right, replacement and everything, like you said, it's well accepted by patients. I mean, it obviously becomes sort of a challenge if you mainly use it for therapeutic monitoring versus therapeutic administration. But it is something that really, I think, as a field in general for DIPG, right, we need to make some additional progress because we are not learning as much from our trials as we should. I think we are starting to integrate some of these measures, but there's still a lot we are missing. So I think that would be something to consider really in future studies, how we could potentially integrate that.
So we have created an umbrella study that allows Omaya placement. At the same time, we do biopsy for newly diagnosed patients together with Mark Sodei at Sloan Kettering. So, and we will be monitoring all this throughout the course. Of course, it would be nice to have treatments that can respond to the spikes. That's the big challenge.
And Sturgis, when you say umbrella study, so any patients newly diagnosed, when they have their biopsy, they will also have an Omaya place sort of as a more like standard of care measure. And then you set out to collect CSF weekly?
Yes, irrespectively of the trial. Let's say if you go even for CED or for focused ultrasound, you name it, that we have this as a translational project.
Okay.
It is interesting that the IRB did not give any grief on that.
Oh, that's great. Okay. That's excellent.
If I may make one quick suggestion. In addition to circulating tumor DNA work that Carl is doing, it's probably worth using the specimens that Carl or others have collected or will be collected to develop other panels that we want to develop, like immune panels, for example, or any other panels that are not currently used as a correlative studies. It doesn't really take so much of CSF to develop novel panels that we currently don't have, but many researchers have started looking into this, so it would be good just to pool the resources.
You mean in addition to the H3.3 mutation looking broader?
Correct. Yeah. Right. It wouldn't be too difficult to develop a panel that we would look at immune markers and elevation of immune markers as a result of opening.
Mm-hmm.
Yeah, and to that question or point, Javed, I guess, Carl, I know obviously the focus and the data so far suggests that CSF is a better way to measure the cell-free DNA. Do you have thoughts? I mean, certainly there's been tremendous progress over the last years in terms of the sensitivity of these assays, and hopefully that may continue to improve. So we may get to a point where blood is a marker, or we may find that with focused ultrasound, actually we can detect this in the blood more easily. Do you think it's in the reality that there will be patients that won't want an Omaya or for whatever reason don't have the ability to do that? Do you have thoughts on kind of how best to pair potential serum and blood kind of evaluations? And again, that would be another source, I think, for kind of also looking at immune correlatives kind of in a similar fashion.
Yeah, absolutely. Javad and I have both, learned that obviously the signals are enriched in the spinal fluid. And I guess I'm not the person to ask about immune monitoring in liquid samples. That's not something that I've dipped my foot into that pool yet. But in terms of tumor DNA, we do find it, the mutant DNA in the plasma. You have to really ramp up the signal and develop assays that are very specific. And so it's a little harder to do things like panel sequencing. But if you develop an assay for specific mutation, we've been able to find those in plasma. And what's interesting is that the allele fraction in spinal fluid may be anywhere from 5 to, we've seen even 50% that what we'll find in the spinal fluid, whereas in the plasma, it tends to be under 1%. And Javad and I have both shown that that actually does seem to, from a patient-specific manner, the ebbs and flows over time are probably telling a story, even though they're very small amounts of the total amount of histone DNA that you might find might be actually mutant. So it's obviously, once it's in the plasma, you're mixing in with all the other organs, right? And so I think it would be great to get to the point where we're able to enrich that signal and get just as much of a story in the plasma. Our early experience from ONC201 phase 1 data is that the plasma is also able to show those spikes and do the predictions that we think are going to be useful in real time. And I think we're just starting to see how that might get moved in the clinic. But to your point, Lindsay, that's going to be an easier leap, right? All these patients are already getting blood draws. And I think if you could just add on to that a blood draw to track where your histone mutation is, then we'd be, where leukemia is, right? Or where following BCR-ABL is, that you're getting 3 or 4 metrics every time you come to the clinic. And it's not one that's overwhelming all the other tests, but it's just a sort of a package picture of how your tumor is doing.
There's a question or more comment from Hidea. I don't know if you want to just unmute yourself and maybe just discuss it, because I do think it's a very important topic.
Well, thank you, Sabine and everybody for great discussions. Yes, I'm Hideo Okada from UCSF. Great discussion about the body of CSF and plasma sampling. But if the blood-brain barrier is completely intact, we're not supposed to see anything in either CSF or plasma, right? So that the detection of something in CSF or plasma indicates there's some degree of disruption of the BBB in the environment of DIPG, either naturally or by treatment induced. Because, yeah, obviously CSF is still a separate compartment from the brain parenchyma, which is, there's a separation by parenchymal side of a basement membrane, part of the structure of BBB still.
I think, I don't know, I think it's definitely an interesting thought to think about. And it may, what you're describing may explain why some of the efforts to look for cell-free tumor DNA, even in spinal fluid, in low-grade tumors, it's much harder to find. The sensitivity is much lower. I know that I don't know to what extent the high-level digital droplet PCR assays have been developed for these lower-grade tumors, and so that might be where some of the sensitivity is lost. But to your point, I think part of the reason we see such a strong signal in the higher-grade tumors is that sort of focal disruption of the blood-brain barrier. Even if it's intact broadly, there's all these necrotic areas and hypervascular areas where that's probably enough to spill out the DNA from the dying cells.
Mm-hmm.
Now, we haven't seen a strong correlation with any imaging criteria with the amount of tumor DNA, whether there's contrast enhancement, some of the that you might expect. But it is interesting how within a patient, that allele fraction does stay very steady, and it really does tend to ebb and flow with how things are going. So it's almost like there's no objective number that means anything across patients, but within that patient, it probably means a lot.
And I think another question, and I think in a very exciting area, and that's also a question for you, Hideo, about how to think about, and I know there are several ongoing investigations, at least preclinical, how to think about using the focused ultrasound technology with immunotherapy. I was wondering if you could maybe comment on your viewpoint, where you see the current field is and where it could potentially go and what potential it might have. And thank you again for a great pre-recorded lecture on that topic as well.
Well, thank you. Thank you for the question. Yes, I see a great potential here by combining with focused ultrasound and immunotherapy. There are some papers already out there in the non-DIPG type model, such as a recent one by Dr. Amy Heimberger's group in clinical cancer research, showing that CAR T therapy, intravenously infused CAR T therapy efficacy can be enhanced by application in combination with this technology, and also antibody penetration can also enhance, not surprisingly. So there's a great opportunity here, particularly DIPG. So we recently started working with a very potent type of novel CAR, which we published recently using hemispheric frontal lobe model. And that particularly potent CAR intravenous infusion works so well. More recently, I started working with Lauren Ferrarosa. One of the she's on the audience panel right now. She started using the same system in the DIPG setting. We don't see any efficacy, and it's interesting that, well, it's a sneak preview of a totally unpublished data about this group. There's, you know, the side-by-side comparison, very potent CAR therapy, intravenous infusion, and the hemispheric model works well, and this DIPG location totally refuses to respond, sort of. So we are looking into this microenvironment, unique microenvironment question, and also application combination with FUS. That's an interesting area. And I know clinically some investigators are working with local delivery of CAR T cells, such as intraventricular CSF space delivery. But also for this, as we just discussed a minute ago, you know, large portion, I believe that a large portion of DIPG tissue still should be separated from even from CSF space. So there must be some degree of you know, enhancement of access that is probably necessary to make this therapy more efficacious, so that T cells can have access to the tumor tissue, tumor cells. So I think there is a great potential for this line of combination. Thank you.
And if there, can I also add on that? I mean, there is abundance of literature on the effects of the focused ultrasound in the immune microenvironment, not necessarily in glioma models, but in general with NK cell activation, with CTLs invasion, activation of macrophages, etc. Do you see any potential of the use of the focused ultrasound in conjunction with the vaccine that you have developed?
Yes, there's a potential for that. And in the brain tumor setting, it's to my knowledge, in the literature, that's the monotherapy, I mean, ultrasound as a monotherapy or one single modality may not dramatically change the immune microenvironment of the brain tumor. That was suggested in Dr. Heimberger's paper, but we are also actively looking at other aspects such as potential antigen presentation, pathway, and you know, endothelial activation in the blood-brain barrier. So yes, there is a great opportunities here to combine with something like a neoantigen targeting vaccines as well.
Fred, I don't know if you want to make a comment with your experience with PD-1 inhibitors.
Yeah, so not specific for DIPG, but prior life I was working on metastatic melanoma mouse models in the brain, and we were using bilateral tumor implantation models where we radiated and used focused ultrasound to one side and looked for a potential abscopal effect and found some local control benefit. And I think that the clear issue for DIPG is whether or not any syngeneic model is truly representative of what's going on in the clinical side. And the second concept is, you know, with focused ultrasound, there's local tumor micro alterations that are immunogenic, seen in Alzheimer's and non-tumor models, but also whether or not you can combine radiation to that. You know, I think there's a lot of power to the combination therapy, because with ultrasound, you'll have sensitization and delivery. With radiation, you may have neoantigen production and also local therapy. So I think the combination therapy seems pretty promising as a way to go.
guess the other big question that we in the clinical arena is what else is planned in terms of focused ultrasound and blood-brain barrier disruption. I think Dennis mentioned earlier that there is a study plan. Dennis, I don't know if you want to mention a little bit more about what your study is going to look like.
I think Dennis had to hop off due to other obligations. That was.
I see.
Yeah.
Okay, or maybe anybody else in the panel of any other future focused ultrasound trials with DIPG.
I think one concept worth discussing on the clinical round is, clearly if you said opening of the blood-brain barrier increases efficacy, every drug seems hopeful. So is there a way or a methodology that as a group we can decide, what's the best way to optimize drug selection for clinical trial purposes?
That's a great question. And I think that would be the ideal. And I think it would be also nice to even think about an umbrella, right, setup in terms of protocol where different drugs could be added to. I mean, we developed a DMG platform trial, where patients can enter at different disease stages, early, newly diagnosed, post-radiation, and then at time of progression. And in that, we are planning to add different arms depending on sort of preclinical data that would support other combination strategies as part of sort of a PNOC DMG Act working group, where also Carl and Jawad are very heavily involved in. And the question is, could something also be developed for thinking about how we select agents that we want to move forward with potentially FUS and add them under the same protocol so that, everything else, in terms of your assessments is the same. Because I think that has been a challenge in the past, right? It was very hard to compare studies in terms of what we know about the patients enrolling. And we know obviously that DIPG, despite that it's in terms of a clinical outcome, fairly homogeneous, it is still a heterogeneous disease. And unless we know what the different subtypes are, it's challenging to really interpret your results, even if it's a 3-month survival. It could be just be purely by biology. So I would love to think about how, as a group, we could think about it. I think the challenge we are facing with the FUS is obviously that you have a drug, and then you have also different ways how to administer the focused ultrasound, right? I mean, some will have the inside tech, you will have your system. And I don't know, I have to say, that I would love to hear from others, is the delivery of FUS, if you can control this, does it matter, right? What system to use, and can we just focus on the drugs and the outcome, or does it matter? And we obviously heard earlier that obviously MRI potentially blunts sort of the effects of BBB opening. I'd love to hear people's thought, how we could potentially move that forward, and what the role of the FUS also might play.
I'll take a first stab at this. So right now there's a big difference between what the machines can do and what we want to do, right? So clearly, ideally, in the best world, we want to open everything, but in most technologies, you're limited to a focus of some sort somewhere. So I think that the trial design and next steps really depend on what can you achieve with current technology versus opening everything. I think in this concept of like chemotherapy, safety and whatnot, not being able to open the whole target or a significant amount of target may be limiting. But one thing that may be hopeful in terms of what we can do in terms of opening, a limited area is maybe combined with immunotherapy and or radiation or something along that lines, where, maybe if you can get enough immune cells in, or if you have some sort of partial delivery, opening a focus itself may be sufficient. So I think, there's a gap between what we want to do versus what we can do.
Yeah, and I agree. I think there's obviously a lot of steps that we need to kind of think about where we want to get to as well, and the idea of kind of an umbrella study, which might, provide some of that additional data, I think is exciting, although also challenging, because I think, we discussed kind of some of the limitations of focused ultrasound in terms of the length of time that the blood-brain barrier may be open. And so, at this point, with some of the limitations, I think we have to think about drugs that may have a longer half-life or that may accumulate in some way, so kind of trying to maximize the potential of these combinations as we start with these first studies, as we gain experience and ability potentially to expand or make them easier on our patients and may be able to deliver more frequently or things like that, then we may be able to kind of even further expand. But I think ideally trying to kind of really maximize the potential combinations with therapies that make the most sense in terms of the potential to, one, drugs that maybe don't get in as well as we want, but there's great preclinical data, but that also have a long half-life such that, you can kind of get them into the, or an accumulation or those types of things. Obviously, we don't always have that information either, but I think kind of really thinking about those potential properties will be important as we think about the earlier studies too.
And the other big question is, imaging endpoints and biomarkers. Obviously, we touched upon the cell-free DNA, etc. But as you saw in our imaging, this is a very subjective evaluation of the blood-brain barrier opening. Of course, we are doing our best with evaluation of K-trans to quantify things with DEC, etc. But any thoughts in the panel or in general about what would be the best imaging modalities and what is the role of PET perhaps in monitoring the studies and the functional response? Yes, sir, we can hear you.
I just wanted to ask the question, in some early studies on GBM and chemotherapeutic agents, apparent diffusion coefficient changes were found to be predictive of positive results. And I wonder if any similar attempt to quantify apparent diffusion change coefficients in DIPG have been done, or in the process of blood-brain barrier opening.
I think the long story short from a clinical level is that there is no data. And the hardest part, at least for our trial, is that you can only give so much gatto, right? And so we're never gonna, at this current time point, be able to get enough imaging data to get enough predictive or do any sort of AI or anything in a meaningful manner. So I think that's something really, a formal talk about preclinical, the potential utilization of, larger animal models where maybe there's a better correlate. But I think at this time point from clinical level is difficult.
I think there have been some attempts to look at some of the more sophisticated imaging. I know some of the Pediatric Brain Tumor Consortium has tried to look across PBDC studies at some of the imaging characteristics and things, but I think there have been challenges in interpreting that. And I guess your point about whether that will be impacted by focused ultrasound and how that might impact interpretation of that is a good question. But another one we should think about as we decide what imaging to include in these trials. I think the question of PET is a difficult one because I just don't think, I think the data in DIPG is very limited there.
Yeah, I don't know. Leo, thank you for joining us. So Leo is a neuroradiologist at UCSF and also helping us to move this forward, at least within our center. Any comments you might have? And I know you had several questions also within the chat. I think it unanswered question, but love to hear your thoughts.
Thanks, Sabine. I mean, mostly I have questions. I mean, I think in terms of like continuous or sequential measurements of blood-brain barrier opening through imaging, I think there may be some potential for ASL to be useful there, which is arterial spin labeled imaging where you can, measure essentially magnetically labeled blood and where it goes, as opposed to gadolinium labeled blood. And the nice thing about that is that you can do it repeatedly over time and you don't have to inject anything. I know there are some people using ASL to measure K-trans now, but I don't know that anyone has actually done that in the context of focused ultrasound. So that would be something interesting to pursue potentially. And then I guess I just had a question, which was prompted by one of the talks that I saw online, and sorry, I forget the speaker's name, but it was this idea that the magnetic field somehow interferes with the blood-brain barrier opening effect of focused ultrasound. And I guess that was the first time I had ever heard of that. And I was wondering if, I guess it was Hong, if she could either elaborate on that, or if anyone else has any knowledge of that. Because obviously, the primary commercial system that we're currently using for this is the InSiTech system, which by definition is associated with a magnetic field.
I can comment on that. So in that study, it was also interesting finding. But it turns out back long time ago, people already looked into fundamental bubble dynamics, the effect of magnetic field on bubble dynamics. There's even equations to explain how that happens, why that happens. But I don't think that discovery is going to affect the clinical application of InSiTech system, for the reason that the clinical system has real-time passive cavitation monitoring. That means, yes, indeed, the magnetic field may affect the bubble dynamics, but we can compensate that effect by doing real-time cavitation monitoring and then utilizing the feedback control and still achieve successful VV opening. But it's just something that we have to keep in mind. The magnetic field effect need to be considered.
Great, thanks for that.
Maybe I can add to that. We do lots of sonications in the magnet, and we haven't seen that effect over 20 years. So there is still some questions how that effect can be repeated, but it definitely doesn't prevent clinical opening of the blood-brain barrier.
I guess we can open into an open discussion for all 3 sessions, if everybody agrees. Sabine?
Yeah, no, absolutely. Yeah, definitely opening up for questions, I think, which came already through to some extent. But,
one of the questions that Suzanne already mentioned that has not been answered is, where do we stand with a upcoming trial with radiation in combination with focused ultrasound, if anybody is planning for it?
So I can take a stab at that one. So we purposely have been doing animal work to look at radiation safety with focused ultrasound. A couple of years back, we did, SBRT or SRS type doses, 30 gray and 5 fraction for brain met, showed it was safe and feasible. Since then, somebody else did a whole brain radiation study, the 30 gray and 10 fractions with ultrasound, so it's been safe. So most recently, we've been doing 39 gray and 13 fractions, which is a clinical dose used in Europe for hypofractionated radiotherapy with focused ultrasound. So we did it in a stepwise fashion. We did focused ultrasound and radiation 1 month post-radiation, 1 week post-radiation, and concurrent. And we also did it in tumor models with concurrent radiation 39 grade 13 fractions with weekly focused ultrasound. Long story short, it was safe to do. There was no motor function, physical detriment. There was a acute weight loss of about a day, but they all recovered, and it was safe to do, and there was no gross histopathological damage that was noted on H&E. So I know from a safety perspective from animals, at least from mice, we have that. Now, our real goal is to establish if this is a working model for combined radiation, ultrasound, and systemic therapy treatment. So this is pretty much fresh off the press, but with this radiation dose in the diffuse midline model that we have a dramatic local control, not unsuspectedly. So we're still waiting for relapse if it will happen. And if they do relapse, then we'll have a working model to look at combination therapy. We have given less dose before, did 9 gray and 3 fractions, which is still maintaining 3 gray per fraction, and using less radiation with focused ultrasound. Clearly, it was safe to do, and they do relapse. So if we're able to get relapse at 39 and 13 with a clinical dose, we'll move forward with that for systemic treatments in terms of preclinical leading to clinical. If we're not, we probably have to choose somewhere in between, a little less, but there's a happy medium there somewhere.
And then can you comment on the timing, how you would envision potentially moving this forward into a clinical trial in terms of?
So I think it depends on which drug is determined to use. We, in our preclinical model, we did, every week focused ultrasound. So, 13 fractions is a little bit over 2 weeks. So it's once a week. We can find drugs that are under that regimen to do, or we can just say it's safe and piggyback off of our panabinostat study that showed, 3 times a week is safe to do and combine it with radiation. I think there's a couple possibilities to do, but those are both to me reasonable.
Lauren, I see some hands raised for questions from the rest of the teams.
Yeah, do you want to go ahead, Mario?
Yeah, just maybe just a short comment with respect to this magnetic field dependence of the bubble dynamics. I read this paper also with great interest. I just want to flag up, I was not sure back then if they actually measured also the pressure of their ultrasound device in the magnet itself, because certain piezo ceramics detune their frequency depending on the external magnetic field. And that is also true for certain piezo composites. And so you need to be very careful that if you build an ultrasound device that's allegedly MR compatible, that you actually not detune your device by just sticking it in a magnet, which is a different effect than the potential Lorentz force on the bubble dynamics. So that's probably something that should be looked into in the context of that study.
Yeah, that's a great question. So that's actually the first thing that we did. We thought it was because of the pressure field change. So what we actually did is we used a fiber optic hydrophone, measured the pressure at different magnetic field to rule that out. And we also, not only we measure the pressure field generated by the transducer at different magnetic field, we found it didn't change that much. We also measure the PCD signal that we get it in different magnetic field in case it's all the magnetic field on the device, not the magnetic field truly on the BV opening. So we did perform all those measurements. But I do agree that this is interesting finding, and definitely we need to look deeper into it.
It's a good point you raised. I'd say you did this very carefully then. So yeah, no, I absolutely acknowledge this.
Thank you for that question. If anyone else has any other questions, please just raise your hand using the reactions button in the lower right-hand corner of your screen. I actually have a question if no one else does at the moment. And this question is for the clinicians on the call, and this is really can go to anybody, not just the panelists, but I'd like to hear from anyone who's willing to answer. My question is, for those of you who are not yet using focused ultrasound and really don't know that much about it, but know enough about it to speak to this question, what is your main hesitation or concern at this point with the technology or with the data that's out there, regarding maybe why you wouldn't want to take it into a clinical trial at this point? I'm just really interested to know sort of what we can do to further advance the technology and the science such that you feel more comfortable if you do have hesitations at this point.
I'll take a step at this again. So we have a study and we are doing it. So here are some lessons learned. We can open the blood-brain barrier to a single foci safely. We've done over 20 treatments and 0 grade 3 toxicity, all under 30 minutes, outpatient, no anesthesia. And we just did a simulation for a 4-year-old. So we're able to do that as an outpatient without anesthesia, without frames. So the real question is, this is a necessary study, feasibility. We understand it. We explain to patients we're opening foci, dose escalation, whatnot, but clearly we are not treating the entire tumor. There's a huge gap in technology from being able to treat the entirety of the tumor as well as the microscopic disease, which ultimately is the most meaningful part. The only other way where focused opening is meaningful is, for example, if you had a radio-labeled drug and that drug has some permeability that you can see, and there's focal areas in the tumor where there is no permeability and you want to focally open the blood-brain barrier, that would be okay. So, right now, I think that's really the biggest limitation of the technology to make any sort of meaningful leap in terms of therapeutic outcome. And then the second limitation is, where do patients go to get this, right? Like it's ablation, one treatment, you're done, you go to a major center, anesthesia, treated, fine. We're talking about chemo, right? And so chemo can be as frequent as every other week, every week, 3 times a week, daily. So how are you going to choose a technology that's capable to do, and then you can do it in a way that's safe to do? So I think those are like the major considerations.
I would fully agree, and I think that is a great response. I think I feel like we had the same discussions when we started our CED trials, where also, right, we couldn't really conduct the whole area, what is really the therapeutic sort of benefit, and then really feasibility. I think that's sort of right, the challenges. I mean, we've shown, at least in our CED trials, that it's feasible, right, to do that quite frequently, and that children can undergo these pretty intense procedures on a regular basis. But it's hard, right, in the long run, and especially for something like focused ultrasound, where it is maybe something where you need to do it at least once or twice, right? I mean, I think the focus has to be maybe on drugs with much longer half-life, different PK, PD effects. And I think that interaction is still right, where we need to really have close collaborations with our neuropharmacologists so that it becomes a really feasible endeavor, right? I mean, I think right now where the field is, right, we are excited about it. I think we are just in the learning stages, but then really the translation into real clinical benefit, if we are opening small areas, right? I think that is still sort of the main challenge. So for me, it's really feasibility.
I would agree with that, and I think despite our enthusiasm, and obviously we started this trial, but there are so many challenges ahead. Examples including not addressing the heterogeneity of the tumor, the tremendous vascular heterogeneity, and we make the assumption, of course we have beautiful science to confirm that, but it still remains unknown to what degree the blood-brain barrier needs to be opened. What it means to have one little spot or more spots open in terms of pharmacology for specific agents. How do we prove that more drug is there, and what is the specificity and the sensitivity of this measure? And why also we're making the oversimplified assumption that more is better again. So despite the fact that it is not as toxic as high-dose chemotherapy with autologous bone marrow transplant, it's a little step ahead, but I can see how many people who try to see this more critically might be a bit more cautious thinking about it.
And I think, I'd echo, I think the challenge of access is obviously a big one, although we do know that patients will travel to the appropriate centers to kind of access some of these more novel approaches. But I think it's the balance of being excited about this as a potential addition to the amazing research that's already happened, but there's still a lot we need to learn. And obviously in the brainstem, given all of the critical neurologic functions that are centered there, we're always a little bit cautious about new therapies that may have a direct and potential toxicity. And so I think it's that balance of wanting to be conservative enough that we don't run into a bad outcome, and that really halts or delays the development of this technology. So I think it's, I think there's a tremendous amount of excitement, but we also want to be cautious and safe as we start these trials so that we can ensure that they can proceed. But there's that balance of not also wanting to do something that's completely subtherapeutic. So trying to kind of find out the safest, best way to combine a therapy that has potential benefit, but that also will help us advance and then be able to hopefully move more quickly in utilizing this in combination with other things.
Thank you all. That was great to hear. Thank you for being so open about that question, even though you know who I work for, and may have been could have been awkward, but it's not. That's why we're here, to share knowledge and truly have the collaborative spirit. So I really appreciate it. I have just one more question, and I think then we can move a little bit early to the roadmap discussion. I think we've touched on a lot of the things that we will want to speak briefly on in the roadmap discussion. But Sabina, I was wondering if you could, you mentioned the CED work that you did, and I was wondering if you could just, if you had any more sort of advice related to exploring a similar area, and that it was a relatively new technology. Any sort of tips and tricks that you would give as we navigate this road ahead as to what to avoid? And I know you've touched on that a little bit, but anything else you can think of?
Yeah, I think that what we are doing here right now, I think, right, I mean, I think if we can find a way where it's a concerted effort from the beginning, I think we are in a much better position to make progress more quickly. So that's why I love the discussions, we had about a combined preclinical group, and then really trying to harmonize how we conduct trials, right? What are sort of the inclusion, exclusion, what are really the things we want to have measured in each of the trials we are moving forward. I think that is really what I learned, and where I felt like we didn't do a great job with the CED trials, trying to really harmonize this from the beginning, because these studies are so challenging, right? They're time consuming for families and for physician and research teams. They're very costly. So I think if we can harmonize and synergize, we will just be in a much better position to inform each other and learn from each other, and setting up frameworks and opportunities where there's this direct communication, right? And I think it needs to happen in real time. It can't wait until the paper is published. I mean, I think that is sort of where I felt like we can do better this time around. And I think that's what was part of my incentive also by participating here, really to get everyone who is interested in developing this, especially for this vulnerable patient population like DIPG, that we can really work together on this problem. And we will all have our separate trials, which I think that's very reasonable, but I think we can set it up in a way that we learn better. I mean, I don't want to say that we had no exchange, right, with the CED. We had a lot of conversations, obviously, with other investigators, but it maybe wasn't organized enough to be as effective as maybe we could have been. I think that's the lesson I learned. And then the other lesson I learned is that I think it's also very critical to collect some of the measures we maybe not have integrated that much in our clinical trials. So we integrated a whole battery of quality of life measures in our CED trials, and we are just analyzing those. But I think that data will be very critical also to inform from a patient and parent perspective. And obviously it's great if you can collect it from both, if the child is old enough, to really what the impact is, right? When, like, I think what was discussed, when you have to travel to a site, right, to get the therapy, when you're, taken out of your environment, and what it means for families in general. So, and I think that is also a very important point to integrate into these trials early on.
Thank you. Any other questions from the audience, or any other final comments from the panelists?
I have a question for the foundation.
Yeah.
So clearly there's a lot of different technologies out there that can do roughly the same thing. From a technology standpoint, what are the hurdles and the feasibilities of doing like a multi-institute study with different devices? And what are the chances of that happening?
That is a great question. And I am happy to speak to that. And Susie, if you could jump on too, to help me address, or anyone else from the foundation as well. I think, you know, there's a lot of challenges with clinical trials in general, namely the cost, as you might imagine. But in terms of being able to do these trials where we're looking at different devices, it just gets back to that like standardization issue, right? Like everyone's doing different things. How many conclusions can we come to that actually make sense if you're using different parameters with different, you know, with different systems? So that's kind of the biggest challenge, is making the results, you know, meaningful once we do have these across device sort of clinical trials. There has yet to really have been such a design of a trial. But we, as you know, are device agnostic, and we try our best to incorporate all the devices into our, you know, study protocols where we can, as different manufacturers are willing to participate. So, I mean, it's something that we would be open to. If we had all the money in the world, we would be, you know, recruiting everybody right now who is interested. So I'll let Tim and Susie speak to this as well.
Susie, you want to go first? Do you want me to?
No, go first. You raised your hand first.
Okay, I'm Tim Meekum. I'm one of the chief medical officers of the foundation, and I have to say that concept is great, but we also have to remember that a lot of the devices are in different stages of their development, and so trying to orchestrate a study for a bunch of different devices, while it's interesting, is not where we see our prime role. I mean, we think our research studies are best in kind of the feasibility and safety study, that then the manufacturers of the device have that information to go after further funding and further you know, seed funding or whatever to move those devices along. So you know, in practicality, I understand the concept, and it'd be a great one if they were all in the same spot, but I don't see it likely to be something that would happen in the future. But the other thing is that we are device agnostic, and we like, you know, competition. Competition is a good thing. It will cause people to keep pressing forward and advancing their capabilities in ways that the overall technology needs. And so that we welcome that, and that's why we hope there'll be more devices, because that's only going to push it further for us. Susie, you may have different comments.
No, I agree with both of you. So thank you for saying that. I think, you know, with respect to what Lauren said, you know, different machines have different parameters, right? If you have a machine with 1,024 elements versus one with 1 element, those are completely different. And I think different diseases mandate different technologies. And listening to all of you speak about the needs of children and perhaps daily therapy or every other day therapy may need a different machine that maybe you can turn on and off at home. If you have a PK of a drug that lasts for 2 or 3 days, maybe they can do something at home to turn it on, or make it easier for them to get it in the clinic. So I agree with everything Lauren and Tim said. I think it would just be too difficult to do the clinical studies across different machines.
The only reason why I'm kind of exploring this is because, you know, from a radiation side, right, we have a gamma knife, we have a linear accelerator, we have cobalt devices, we have whatever. And the goal is to give a well-defined type of radiation, standard local focal radiation. And so if you had a brain tumor SRS style trial, you would not have machine choice. You'll be open to all, as long as you get delivered type of radiation. I think at some point there needs to be a vision where it's the parameters of opening, whatever it may be defined by the foundation or someone, can these machines meet that parameter? And if that parameter can be achieved, is there a possibility for cross device? Because otherwise you're just going to have these small trials everywhere, and you're not going to be able to, you know, do next step stuff.
Yeah, I mean, and I think especially for the pediatric population at this point in time, the availability of any clinical grade focused ultrasound device is scarce. And so that is something that, you know, as we increase awareness and as these pediatric trials and different indications pop up, I think that will change. We've definitely made some progress in the past year or so with sort of the reinvigoration of our pediatrics program here at the foundation. And, you know, we're going to do what we can to increase the availability of these devices, or at least the awareness, so that people are interested in exploring this as a potential option for their pediatric patients. Just to tag on to that, I mean, I think the other thing that we are really passionate about here at the foundation is that idea, again, of collaboration. So even if we're not doing, you know, a clinical trial that is, and this has been spoken of multiple times by multiple people, but even if we're not supporting a clinical trial that uses multiple devices, that's not to say that we don't encourage people to sort of have those discussions, and we would be happy to, you know, host sort of those quarterly meetings of the minds, if you will. And I just feel like DIPG in general is such a great population to start with, because just from what I've learned in the past couple of months, you know, organizing this workshop, is that as a community, you all are excellent at collaboration already. And it really shows that you care about the patients and you put the patients first. And so I think it's a great opportunity to do more collaborating beyond, like, you know, the DMG collaboration that you already do, the PNOC initiatives and whatnot. So I think we are happy to support all of the collaboration that you guys want to do. If you have any requests, let us know. But more information sharing is better, in my opinion, for the patients. And that's really what we're all ultimately here for. So. All right, so at this time, I think we can probably move to the last portion of the day. And I know we're all getting Zoom fatigue, so we'll be mindful of that, try to keep this around 15 to 20 minutes or so, or even less if no one has anything to say. That should not prevent you from saying anything. But anyway, so if we could have the moderators turn their cameras back on, and we'll pin them. So that would be Sabina, Kalervo, Sturgios, and Mehmet, and Javad. Sorry, today is getting late for me as well. And this time is really for us to come up with some true next feasible steps for the Focused Ultrasound community, for the DIPG community, for the Focused Ultrasound Foundation to sort of have our eye on, in terms of where we really see that meaningful next steps can be taken. I have a couple of notes written down just from actually what Sturgios had just mentioned, the issues with tumor heterogeneity, the degree that blood-brain barrier opening needs to be achieved depending on which molecule you're using, and just in general expanding the treatment envelope. I think those are areas which can be explored preclinically and then move to clinical, you know, later on when we discover some information. But I'd love to hear you guys' thoughts on just what you've picked up on today so far, and where you think we could support some research, you know, create meetings of the minds, that type of thing.
Lauren, thank you. Maybe I can start from the preclinical work.
Yes.
So I made some notes from what was discussed with the panel. I think the consensus were within the preclinical group to develop a working group, and some of us have been emailing back and forth. I think there's a huge need for this, specifically to share data, specimen, and models, and model characterizations. What are the models that we're using? How diffuse is the tumor that we are testing? And also, there was an agreement for the need to centralize the histopathology. We need to really work with expert pathologists, Dr. Hawkins, etc., to see that the type of tumors that we are working with is representative of the clinic, but also the damage that we see from the focused ultrasound in addition with radiation and drugs. There was also an agreement to explore larger animal models. This would be dogs or or swine models that we would be looking into the need for developing microdialysis for assessing drug penetration. And again, this would be within the consortium of the preclinical working group. Immunocompetent models, I think Jin Huang also had a comment in there, and Hideo also commented for the immunotherapy folks, developing immunocompetent models is important. And also looking at the correlative preclinical studies with the clinical data, I think we should be in constant contact with the clinical colleagues. And Fred, for example, would be an excellent person because he knows both sides to communicate this with us. And the last one, I don't think was a consensus, but to have an in-person FUS meeting in 2022, hopefully in Washington, DC.
Thanks, Javad. Yeah, I totally agree. Let's do it. Lervo, any final thoughts?
I can't keep up
so-
with Javad. Oh, sorry.
Oh yeah, go ahead. Go ahead, Sabina.
Yeah, no, I mean, he's already having a nice slide and having it all mapped out. So, but I would say what I took away, I think it would be really great if as on the more clinical side, you know, we can really start to think about at least harmonizing of sort of maybe the development of a protocol template as we move this forward. What are sort of things we consider is a must in the inclusion, and what is a must in terms of what we want to capture, and then also working with our radiologist, you know, to really think about what are some of the MRI sequence we do want to incorporate, and obviously what we heard from Carl Koschman also earlier. So I think a great achievement if we will have this in-person meeting, if we could develop a framework, really what are key elements that each protocol that we are moving forward with the different strategies should include. I think that would push the field definitely very much forward. That would be my ideal if we could develop this over the next few months.
Thank you.
I also wanted to make a comment. This is fantastic, Javad, and the whole idea is that I think this is the perfect example, especially the focused ultrasound and the way that we anticipate it will be incorporated in the therapeutics, to think about the future going with developing clinical information where we address the needs that we have in the clinic and feed them back to the preclinical laboratory where to address them, as opposed to the typical where we find something exciting in the lab and we move it to the clinic, because this feedback is essential for this technology, I think, because there are so many caveats and so many challenges, as we discussed earlier, that we need to fix.
So maybe I can answer by the technology. So there have been lots of questions saying that this is a spot technique where you just have small spots, but that's not actually true. With the current technology, the focus is scanned over a larger area, and so you can fairly precisely control the shape and size where you are modulating the blood-brain barrier. Yeah, I'm sure in the clinical systems, spot control will be very soon available for patients. In animals, it is routinely used. So we sweep large areas and get uniform modulation of the blood-brain barrier by controlling the exposure for each locations. So that the technology is there, and it's almost at the threshold of clinic. So I don't see any issues. Even if you have to scan the whole brain, that is feasible with electronic beam steering. So I would be very optimistic on the technology side. So it's now the questions are the clinical and the drug-related questions. What drug to use and when to treat and how to treat, and then of course the patient interface to get out of the MR scanner with the more sophisticated systems and do it outside, so it's easier to treat and faster. So.
And I think on that issue with the technology as well which is linked to the clinical trials in the future. We obviously, for example, in our trial, we're using one very specific device who is not commercially available yet, etc. So it would be nice to start having feasibility studies of very small in nature in terms of number of patients needed, etc., to explore the feasibility of other devices as well. And also the biggest challenge of all, how is this technology is going to become available to a broader spectrum in many centers? Because there's no point of, for example, one center developing one technique that you can just use the ultrasound to open the blood-brain barrier if this technology is not transferable and not applicable to patients who live abroad, or I think that's a major issue.
Yeah, no, absolutely. I agree with that. Commercialization needs to be the end result of whatever is developed. So that is clear. And I think people are working, there are several companies working in this space.
Okay. Anything else from anybody? I think this has been a really great discussion. I think we have some great, actionable items here that we can work with, and you should be expecting to hear. Oh, I see a hand. So Mario, go ahead.
A very quick question to Kullervo with respect to technology. What was a little bit out of the discussion is actually the bubble as part of that technology. Do you see any innovations, improvements on the bubbles that should be incorporated in these studies?
So at the moment, it looks like you can kind of use almost any bubble, but I mean, that's a very unexplored field. So I see lots of advantages. Advances can be developed by developing special bubbles and depending what you want to achieve in a clinical setting. But I would say that the current bubbles work well enough to demonstrate clinical feasibility for delivering more drug in a tumor or in brain, generally speaking.
Would you, for example, is bubble lifetime in the circulation a point where that should be improved? Because that also really has a direct impact on the volume that you can open, because when you can give a large double bolus, double dose, but at some point you have to stop injecting bubbles. So if those stay longer in the circulation, for example, that would open the possibility to have larger volumes that can be opened at a given time.
That's a good point. In a clinical practice, we are doing infusions right now. And we are using, if you would be using boluses, we would be using much smaller boluses than for imaging. And we can open as large volumes as we want. So, I mean, the bubble infusion dose is not limiting us right now, in Canada at least, and patients seem to be quite safe. So.
Thank you.
Hey, it's Fred here. I just want to add one more comment. No, I think this session and the collaboration is amazing. I'm a clinician, I'm not an engineer, so no matter what I say is somewhat limited. But my hope really is that from a technical side, maybe the different devices, those who have stake on the different devices can come up with a common goal with the clinicians of what needs to be achieved. And once we decide that, whatever that goal is, have the devices work towards that goal. Therefore, if each device can reach that goal, then there is a potential for cross-device trials. Right now, every device is working on their own version of the best, and it's very good. But for the clinical side, it's really challenging to do any sort of studies. So if there's any way the devices and the clinical side can say, all right, our goal is to open 50 cc's in the brainstem, and then we let the device companies or whoever's involved try to achieve that. And those players that can do that then have a potential to be enrolled in a multi-institutional trial. That'd be great. Otherwise, I just don't know how we will ever be able to use different devices, and maybe that's not the goal. I don't know, but for a clinical side, it's really challenging.
That's a very good point. Maybe I can take a stab on it. So I think that the goal, all the companies, manufacturers have the same goal. The thing is that the technology is maturing at different rates, and that's why some people have single element transducer, others have 1,000 element, and others have 4,000 element arrays. And receiving mapping signal spots and things like that. So it is just a question of where the technology is. I think everybody wants to do the same thing. eventually sweep the whole brain, any location of the brain, it's from single spot to whole brain. So and quickly. So.
And I think, everyone's trying to achieve that maximal endpoint, but if there's an intermediate endpoint where clinicians feel comfortable and devices feel comfortable, and we set that benchmark of wherever it is, devices like yours that are maybe more advanced, you're already there. Devices that are less advanced, they know where a target to reach, so that once they reach it, you have an ability to do that. That'd be really great, because clearly at some point, there's going to be different manufacturers doing the same thing. And we need like a set benchmark. Like, for example, with radiation, the goal is not how you deliver the radiation. It could be cobalt, it could be LINAC, but if you can achieve 20 gray to a spot with a high dose fall off, that is the goal, then it doesn't really matter. So if there's a engineering side happiness of where this next step benchmark could be in the clinical level that the physicians are happy with, and we tell the technology, do your best to get there, and those who eventually get there can join the group. Those who are not, you can work towards it. That would be ideal. Otherwise, everybody's trying to reach for an ideal part, and who knows when that's going to happen.
Good point. I'm happy to write a description if people want to know what we are aiming for.
Susie, I see your hand up.
Yes, thank you. So thank you, Dr. Wu and Dr. Heinonen, for those comments, because I do think it's so important to come up with almost a consensus. And Sabine, I was hoping that you have such extensive experience convening the community and coming up with consortiums. And you mentioned the difficulties in kind of harmonizing the protocols under the endpoints. I was wondering if you could give the foundation, Lauren and I and Tim, any advice on how we can start to convene this working group and what our realistic goals should be and how we can get people to harmonize endpoints. Just some more lessons learned and what we could do moving forward.
A great question. So we are currently exploring this for low-grade gliomas within a larger, really international pediatric low-grade glioma coalition. And part of my role together with Dr. Witt from Germany, we are trying to set a framework to really, again, because there's so many low-grade glioma trials being done, but they all have different endpoints, so it's hard to compare outcomes. So similar challenge, obviously very different field and area. And I think it worked well. I mean, so far we are almost done. We had monthly meetings, really working meetings. I mean, we literally sat down and started drafting some of the sections of a protocol components. And I think if you have people who are really eager to contribute to this and will move this forward, I think that's a very achievable goal. And it actually doesn't take that long, depending, the challenge is obviously, we all do this in our sort of quote unquote free spare time. And that is sort of a challenge, right? How do you do this outside your normal work? And I think this is where the FUS Foundation could play a role, right? To maybe support these kind of efforts. But I think, what I'm hearing today is really encouraging, right? That everyone wants to drive a field forward, especially for children with DIPG, is very willing to share and harmonize. But I think it just takes organization and sort of a time commitment from people. And that's obviously the challenging part. You need to have somebody who is really driving this and leading that. Yeah.
Okay, well, thank you. And I will surely be following up with you to get more specifics on that. So thank you.
Anything else from anybody? This is your last chance. Okay, well, we have a lot of material here to sort of review and comb through and make sure that we've got the important parts, but I think we hit on a lot of high notes today, and this is just the beginning of, of this area of study. And hopefully one day we really do see this, save patients' lives. So I am very hopeful for it. And I hope that you all are too. I want to give another special thank you to our moderators today, who are also our steering committee. Big thanks to Javad and to Claire Vo and to Sabina and Sturgios and I just cannot thank you guys enough for all of your time and efforts put into this. And thank you for letting me call you by your first names because they're easier than your last names. And with that, so be on the lookout for a couple of things from us moving forward. We always create white papers for these sort of events. It will be, a summary of everything that we spoke of today and include, our next steps and how you can get involved. So that should be coming in the coming months. It does take a little while to produce, but will be very valuable. And then, we're going to put our heads together here at the foundation and come up with a game plan as to how to move forward on some of these issues, and we will be recruiting your help. So thank you again for being here. I hope you all learned something today, and we will be in touch soon. Susie, anything else to add? And thank you to Susie as well. She was a huge part of this.
No, thank you, Lauren. Thank you, everyone, for sharing your research, sharing your experience, sharing your expertise. I hope the people that haven't been involved with focused ultrasound before have a greater appreciation for the potential impact of this. I'm also really excited, right? We always think that pediatric tumors lag so far behind adults, and we do have some years of experience now with focused ultrasound in the brain and adult brain tumors, but I'm thrilled that we're now moving into the pediatric realm. I think the possibility of targeted drug delivery, radiation therapy, and STT is great. So thank you everyone for sharing your knowledge and your thoughts.
And thank you from our end as well for Lauren and Susie. I mean, you really organized this and made that happen. So thank you.
Thank you very much.
Thank you. All right. Have a good rest of your afternoon, everybody. Thanks so much.
Thank you.